is the director of the Division of Family Services with the Virginia Department of Social Services. Kristen is certainly dedicated to the mission of improving the lives of children and families served by improving their permanency, safety, and overall well-being and outcomes. She has sort of a trifecta of human services experience, as she has worked both at the local level as a child protective services worker in Fairfax County. She's been with the state, of course, at VDSS, and she's also worked at the federal level with the Center for States. Joining this morning's panel is Bethany Embody. Bethany is a member also of the Division of Family Services at the Virginia Department of Social Services and serves as the Capacity Building Program Manager. Bethany also has a great deal of experience and knows about delivering direct services to children and families, which are supported by the CSA system of care. Her introduction was accomplished through her work as an intensive in-home clinician and therapeutic foster care social worker. Lastly, I'd like to introduce our third panelist, April Evans. She heroically stepped into this role as one of our presenters became ill, but she is more than prepared to share with us some knowledge that she has learned through her 18 years of experience with the Henry Martinsville Department of Social Services, the foster program, and adoption programs. She's also served as foster care supervisor, and currently she is the Assistant Director of Services. I'd like to say good morning to all three of our panelists, Kristen, Bethany, and April. Thank you for being with us and sharing your wisdom on the topic, Social Services Response to COVID-19, Connecting, Communicating, Collaborating in a Virtual World. Thank you. The floor is yours.
Great, thank you so much. We are excited to be here, and we appreciate the opportunity to talk about what we've done at both a state and a local department level in addressing the urgent response to COVID-19 and looking at how that has opened some doors, how we can transform some of our work to the virtual environment, and what we're looking at as we move forward over establishing our new normal in this virtual environment. So with that, I'm excited to bring this forward with Bethany and April, and we will go ahead and get started. So today for our agenda, what we are doing is we're going to look at our shared response. We're looking at our connections, our communication, and collaboration. And then we're going to look at the ongoing needs that we've identified moving forward. We're really excited to look at this as a collective child welfare community, in that we all contribute to how we're able to certainly address, prioritize, and meet the needs of the children and families in our communities. So in looking at that, as we look at leveraging our roles, one of the things that we wanted to kind of bring forward to start off this presentation is really talking about the partnership and the interplay between the state, so the Department of Social Services at the state level, and the Department of Social Services at the local level. So at the state level, we are accountable and responsible for writing and developing policy, guidance, and training to be able to support best practices, and then identifying resources and providing partnership to be able to bring those resources forward. At the local department level, the responsibilities are to deploy those resources, tools, and guidance to make sure that we have staff, and the staff are well trained and know our policies. And then ultimately, the responsibility is to make sure that we're providing the best services we can to the children and families, and doing that obviously with our community and with the service providers. So as we look at our next slide, what we're going to do is talk about a couple specific areas. We're going to talk about how we look at our data, how we are working with parents and foster parents and establishing supports, looking at that communication, looking at worker supports, which are incredibly important during this because we need to have a well-supported and safe workforce for them to be able to work directly with the children and families. And look at our partnerships, both at the state level, the local level, and with private and public partners. So with that, we'll go ahead and move on to the next slide. So one of the things we did at the state level, starting back in March when the pandemic really hit and there was a lot of crisis going on, we looked at what we needed to do to recognize our workforce as emergency responders. Our workforce, so definitely the folks out in the field going out every day, are first responders and need to go out. So one of the things we did is worked with the governor's office on establishing essential personnel and looking at being able to build out a role as emergency responders as we go forward. The other thing we did is looked at bringing virtual technology so we could do virtual visits and change guidance and policies according to federal guidelines to allow for that. We were supporting teleworking. We made a lot of regulatory waiver changes in primarily the foster care area, letting up on some of the requirements so that children could be placed in foster care as easily as needed. So just making that more accessible. We were doing data analysis. We're looking at enhancement payments for foster parents through the BMAT, and looking at our collaboration and moving all of our trainings over to virtual. So with that, let's take a look at some of these. So if we look at our data on the next slide, one of the things that we saw over time is there became a concern about the decrease in the number of calls to our hotline. And when we say the hotline, we run a state hotline, and each locality also runs a local hotline, and that's for the connection, obviously, to the community. So these numbers reflect both the calls we get at the state as well as the calls at the local level. And so with this, as you can see, the green line is where shows our calls for the calendar year of 19, and the orange shows the calls for the calendar year of 20. And in that, you can see in March and April, there was a significant decline in the number of calls. And that was primarily calls coming from the schools. And so because children weren't in school. So we saw levels, as you can see in April, that are pretty consistent with the levels that we would see when children are out of school in the summer. What was concerning is that when children are out of school in the summer, they're also in other activities. They're in activities with camps and clubs and sports and things like that. So the social isolation was also a concern. As you can see, as we go through the year and as we go into September, we are kind of going back up in those calls. And as you can see, as people start to open up, as schools start to open up, we kind of see those differences. So we'll continue with that. And I will jump back to how we're working with the schools around these calls as well. The next slide shows where we're at with the number of children who, I think one more slide back, maybe slide 7, if we're on that one. Here we go. So this slide shows our number of children who are entering foster care. And as you can see, the orange line represents calendar year 20. And as you can see,
Kristen, excuse me 1 second, sorry. April, can you go to the display settings on your Zoom screen right now? And it's up towards the top. If you hover over to the top where it says display settings on your PowerPoint, next to show taskbar, and then click swap. There should be a button that says swap. So that display settings button. And if you click that, there should be a drop down. And then that first one that says swap. Perfect, thank you.
There we go, thank you so much, I appreciate that. And thank you, April, for keeping up with me. I appreciate you following along. So if we are able to go to slide 7, there we go. So this is the slide. So I'll talk about foster care again. I'll kind of start over, but So as we're looking at this slide, the blue line represents calendar year 19, the orange line represents calendar year 20. And as you can see, consistent with the number of calls we're getting, the number of children who are entering foster care has also reduced, which is also consistent with the calendar year and the school year in the summer. But as you can see, those numbers are going up, of course. We are here talking with all of you today because our goal is to be able to try to make sure that children can be safe in their community, with their families, or with their kin when at all possible. And so although we have children coming into foster care, our goal remains to work with children and families to make sure they can remain in their community. So on our next slide, on slide 8, what we did to help with worker safety is we're able to put together some tools and some guides that would help workers be able to assess their ability to see families and children face to face. That's one of our #1 charges in child welfare, is to go out and see the children and families to ensure safety. However, we have to ensure that our workforce are safe in order to do that. And so these are some of the guides that we put out. And on the next slide, on slide 9, we have something called Compass Mobile. I'm sure you've all heard of it. It's fantastic. And our workforce has really been able to use this to be more nimble and more flexible in the field. And what this is this is a screenshot that really shows what the Compass Mobile looks like. And we put a icon, you can see the red circle, where it would hold all of any of the resources that were out there nationally at the state level or at any other private foundation level. So workers could tap into those right away. And then we also had the opportunity for the DoxyMe, which is what we said, which is the virtual platform where workers could do virtual visits with the families when safety was an issue. So COVID safety was an issue. So we continue to do that. And so with that, I'm going to move on to our collaboration. So with collaboration, one of the things we did is we collaborated very closely with our community partners, with the local departments, and really looked at what could we do together to make sure we're able to really get the word out and work together. So we worked with the Virginia Department of Education, and we worked with Families Forward, some of our partners, to put out some literature on how school personnel could assess children when they were still at home and working in the virtual environment. And those partnerships have proven to be pretty successful at the state level, and the regions and the local levels have been able to modify some of that information to be specific to their localities. And with that, I am going to turn it over to April, who's going to talk more about mobilizing our workforce at the local level in a virtual environment.
Sorry, I need to unmute. Good morning. I do apologize. For some reason, my camera is not, I'm not able to get my camera on. So I do apologize. But just wanted to share with you guys that, so from a locals perspective, it is our focus. We focus on the child safety, permanency, and well-being, as well as the health and safety of our workers. All of the decisions that we make at the local level has been strictly the safety of our workers and the staff that are in the field. We have provided personal protective equipment, such as masks, gloves, goggles, and hand sanitizer. We have also supplied our staff with thermometers, the contactless thermometers, where as we are out in the field, they are able to check temperatures. As I stated, our director has been very cautious and just really looking at the safety of our workers. So we have put precautions in place as far as when we are going out into the field, we are asking the COVID-19 screening questions. And then, of course, if it is not safe for the contact to be made, then we are doing the visits virtually. So at this point, Kristen, do you want me to do this, or is this?
Sure, April, thank you. I'll jump in. So what we're going to do is as April goes through some of her other slides, what we wanted to do is ask you to think about how the transition to the virtual work environment has enhanced partnerships between the local departments, service providers, and stakeholders. And so we encourage you to type in the chat feature your thoughts and your ideas about that. And in a couple minutes, we'll circle back to that and have a virtual conversation around your experiences with the virtual environment that we're in and how we move forward with that. So thank you, April. And we will see the same slide just in a couple slides.
Okay, so from a local perspective, as we moved into COVID-19, the initial assessments that we looked at obviously our available resources, as well as our areas where we saw areas of growth. We did, as far as the resources, we saw adaptability of child welfare staff. Telework operation was operational, and of course, Compass. We were fortunate to have a staff that were adaptable to the changes that obviously had to be made to prepare for the COVID-19. Obviously, there were challenges getting there, but we did truly have a good group of staff that was able to adapt to the changes in the transition. As far as telework, fortunately, we were already, our director had been proactive in getting the supervisors as well as the lead staff was already in the process of teleworking. Prior to COVID-19, the supervisors and the senior workers and the lead staff were already utilizing telework on occasions as needed. So that was obviously a resource for us because we were already, most of us were already had the capability of teleworking. And then Compass, obviously Compass was a resource. I mean, this was a tool that we were able to tap into to be able to work remotely. Of course, the Compass team has been amazing, and they really have stepped up and really helped us through this transition. Some areas of growth that we identified was the CDC guidelines for worker safety. Of course, we had to learn and comply with the CDC guidelines. We worked on creating policy, obviously with the assistance of Virginia Department of Social Services, as well as the CDC guidelines. For the safety of our staff. And then another area of growth was the personal protective equipment. Obviously, that was something that we quickly had to put in place. We were able to secure masks, gloves, goggles, and hand sanitizer. That was provided to the staff. We fortunately were able to reach out to some of our community partners And we did receive donations. We also worked with our local public safety, who did provide some of the personal protective equipment through the CARES Act funding. And then we also, there was limited work exposure. Our director was very cautious in sending our workers out in the field. So we did put some limitations as far as the staff. We had limited staff in our building at that time. As far as the child welfare staff, we were working remotely. We were only seeing, of course, Child Protective Services and Adult Protective Services was obviously out in the field. And then we also were seeing our high-risk Child Protective Services ongoing families. But outside of that, we did limit exposure to our staff. Another area was the child welfare hard files. As we transitioned into working remotely, this was a challenge for us, just not having access to the hard files. So that is when where Compass has brought in a huge role and has helped us. Obviously, we are uploading into the we're uploading our documents now, and so we are transitioning away from needing the hard files. And we do have a goal of being paperless. I believe it's May of next year. So we are working towards that as well. And then another area was our supervised visitation. Prior to COVID-19, we were we had 2 designated rooms in our building that we used for supervised visitations, where the children and the parent and or guardian would come in and visit with their children. Obviously, our building was closed, so we did not have that option. So that was part of an area where we had to figure out some different policies. So initially, the foster parents were supervising contact with the families via teleconference, telephone. So that was a challenge, just trying to figure out, what we were going to do as far as our supervised visitations. So moving over to employee morale. So there are some fun activities that we did try to put in place just to try to keep employee morale. Obviously, this was a challenging transition initially. So we wanted to make sure that we were keeping our staff connected. So some of the virtual teamwork activities that we did put together some virtual team building activities. Our director coordinated a team building activities. Specifically for this activity was for the leadership team, which is all of our supervisors. And we, one specific activity that comes to mind is she's had all of us take a picture of our refrigerators. And so we had to come in our meeting, we came together and each one of us had to pick whose refrigerator belonged to whose home, which was very interesting, very entertaining. So that was just, again, just trying to keep connection within the supervisors as well as the leadership team. We also have an employee fun committee that hosted virtual game days where we broke out into smaller groups, and whoever won the game was given, I think, an Amazon gift card to where we could, just trying to keep the connection, and also did it in smaller groups, just, where people can socialize and stay connected. And then our director did do, on occasion, she would host Zoom hop-on sessions, and this was to discuss just any current topics that the staff may have. This also gave the staff the opportunity to just socialize with each other and stay connected. And so these were a few of the team activities, team building activities that we have done with the staff. And then also leading from a distance, we have continued to move forward with our vacancies. We have filled our vacancies very quickly. We have continued to do those via Zoom. That has been very successful. Then we also have the county, our Henry County Board of Supervisors provided all Henry County employees with a county stipend. This was, as I stated, approved by the Henry County Board of Supervisors. Of course, this was supported by the Deputy and County Administrator. They have been amazing support to all of Henry County staff, specifically our agency. And this stipend was just to continue to support the staff that has continued to work during COVID-19. And this was not funded through CARES Act. This strictly was local only funds. So we truly appreciate the support that we have received from the County Board of Supervisors, as well as the Deputy and County Administrator. We continue to have our monthly conferences and staff meetings. Supervisors continue to have monthly conferences via Zoom with their staff, as well as staff meetings. Just to stay connected before COVID-19, we were doing those monthly, but just to keep everyone connected, we did start doing those on a every other week basis. So, and we still continue to do those just to keep the staff engaged and connected with each other. We've also had two leadership team building, trust and virtual performance. We've just leading from a distance. We all have had to learn to trust that the work is getting done. We've also created some virtual meeting expectations just to remind the staff that, just because we are behind a camera, we still, are promoting professionalism. Of course, we, ask that your camera is on at all times, unless your camera is not working, as my instance today. So that has been helpful, just to kind of put those expectations out there, just to kind of let everybody know what to expect. And then we also have allowed for flexible work schedules. And this, has really allowed, as most of us have children and virtual learning, so this really has opened up some opportunity to be flexible with that, as well as childcare. And so, of course, we want to flatten the curve and not our spirits. And let's see. Okay, moving on to the next slide, our family time innovations. As I spoke earlier, we really have struggled with finding ideas as far as supervised visitations with families continue. We have recently put in place where we are going out to our local parks to do supervised visitation. Of course, we are practicing our social distancing where the child and the family, as well as our staff, is visiting, is supervising those contacts at a local park. Also wanted to mention that, as you can see in the slide, the playground, we are in the process. Our director has worked diligently and very hard on getting several grants, and I believe the total of the grants was $27,000. I think it was a total of 3 grants, and that was through our Harvest Foundation Board, as well as several Rotary clubs. So they found the importance of us bringing our families together. So we are, by the end of this year, we'll be installing the playground. We do have an empty grassed area beside our building, very large area. So we are very excited to see the playground be put in place where the we then can supervise our visits there at the agency, where the families can be there with the kids, and this is something that the families can certainly enjoy, you know, throughout, and also just with us getting the goal of permanency with our families that we work with.
All right, well, thank you, April, for that section. And we're gonna go back to this question that we put out for folks to kind of think about. So kind of hearing some of the work that has been going into transitioning from the way we knew how to do our work to the way we are doing our work, and how that comes together with the service providers and our stakeholders and partners. We're encouraging you, if you want to type in any thoughts about how you have adjusted, and then how we're working together with that. In terms of one of the questions that has come in is, how has COVID-19 affected the turnover rate at the local level? April talked about the workforce and the hiring practices that they're doing virtually and over Zoom right now in her county. Overall, we have not seen a change or a difference in our turnover rates as a result of COVID. One of the things we have seen, though, is the flexibility in the localities, and April talked a little bit about that. But we have to make sure that folks are flexible for all of the virtual schooling that is going on in the dual role you're doing at home. Plus, in this work, as all of you know, I'm not saying anything to anyone on here who doesn't know, but we definitely look at the impact of trauma on everybody, on the whole system, certainly on the children and families, and then the trauma that we all experience as doing this work. And so we want to make sure that our workforce gets to stay connected, gets to have that time that they are able to process. And April was talking to us about some of the great team building activities and different things that they do virtually to be able to keep their teams connected and be able to attend to the needs of our workforce and make sure that they have places to go. So I think that that's really important. The other thing is, some of the local agencies have had, especially some of the smaller local agencies, have had to really make some significant adjustments because of some COVID exposure in some of the offices. And so some of the offices have had to actually move locations. Localities have jumped in to help each other out in with their hotlines and with even going out and making initial visits on investigations. So we've seen a lot of community response, cross-community response, and regional response. And so, so we've seen connections being made in all of those areas. So I think with that, we have one of the questions talking about, can we talk about Compass a little more detail? So sure, we always love to talk about Compass. One of the slides you saw, I was talking about Compass Mobile, and one of the things that we were able to do over this last year, actually right before March, right before the pandemic hit, is we were able to roll out something we're calling Compass Mobile. And what that is, it's iPads that went out to all local staff in family services that are allow workers to actually have access to what we call our OASIS system. So workers are able to go out and put in their case notes. They're able to pull up all their information. They're able to work directly with the families with the iPads. Children can actually type in messages and emails that are sent directly to their parents. They're able to, it's a very interactive tool. And so that's one of the things that we're able to use. And because of that, the workers are able to use the Doxy.me, which is a virtual, it's like Zoom, but it's a virtual platform, but it's HIPAA compliant and it's PII compliant. And so that way workers are able to have direct communication with families and children within the confines of the HIPAA and the PII. So they're able to do that through their iPads as well. Of course, any of us can do that through the computer, but if the workers are out in the field and they're driving around, they're able to go ahead and do that in between their meetings, in between their stops, and actually pull over and get caught up with their notes. So it's a very well received and very positive virtual support for staff. And as a matter of fact, I know that Virginia has been highlighted at the national level for having this opportunity for workers to be able to use during COVID, because they were able to be nimble and access all the information and continue to meet with families without a significant transition to that virtual environment. And then what are some of the examples of working with schools and the virtual attendance? What I'm going to do with that question, Bethany, we're about to move into a section where Bethany's going to talk about our communication and some of the collaboration we were doing around safety and with the schools. And so I think she will hit on that question. And if not, we will certainly go ahead and pick that up in the next part, so we make sure we answer that for you. So with that, Bethany, why don't I go ahead and turn it over to you, and you can kick it off with our communication.
Great, thank you so much, Kristen. So thanks, April. Yeah, so we are going to talk a little bit about our collaboration and joint prevention efforts in this next section. And we will talk about our collaboration with the school within this section as well. So we knew when COVID was hitting initially that given our situation as a large state agency, we had not only the vantage point of a systems level responsiveness and ability to affect outcomes, but also the challenge of a massive structure within which to move. And we did not have the luxury of time, of course, like nobody did, while trying to address unforeseen challenges coming at us. And most importantly, the challenges that were rapidly hitting the 120 local departments across the state, which are imperative, of course, to children and families' safety and well-being. So while we have had really strong partnerships with our other state agencies and community providers, as well as our local departments, this period called for very intensive, rapid, and highly effective strategic collaboration in order to fill the gaps caused by the pandemic. So social isolation, of course, school closures, of course, and all the other factors that this time brought with it. We also saw an intense need to be able to brainstorm with our partners across the state to not only be responsive to needs, but to also come up with informed understanding of what the immediate and further future might bring. So we mobilized in numerous sectors and realms, first with our local agencies and the League of Social Services Executives, which represent about 80 of our 120 localities that PDSS serves. We needed to understand clearly what those needs were, and we knew that the needs were diverse, of course, representing diverse areas with geographic and economic variances. We also knew that we needed to partner with our court improvement program and our court and judicial partners, particularly initially with court closures, which of course impact child welfare cases. We also partnered with the Department of Behavioral Health and DMAS and OCS to look at residential placements in this time when congregate care settings implied additional risk. And we mobilized regular brainstorming sessions with our partners like Voices for Virginia's Children, the Virginia Commission on Youth, Virginia Kids Belong, and Families Forward, in order to see where their unique strengths and resources could complement our efforts and our abilities. So we also, what I had spoken to on the last slide involved partnering immediately with our local departments, of course. So we partnered with Fairfax County Family Services. Fairfax had provided a really tangible resource, I think around September, late August, September, to address prevention concerns that accompanied the school closures. And we knew, of course, Fairfax knew, we all knew with those school closures and that increased social isolation, there are fewer eyes on children and incredible new stressors that compound pre-existing stressors for families. Fairfax had developed a toolkit to address specifically in their Northern Virginia community how to mobilize all players involved in child and family services toward preventing abuse and neglect and supporting families. So Fairfax graciously shared their materials with us, and our projects team quickly transformed that resource into a generalizable toolkit usable by all LDSS, all 120 local departments in the state. It included things like social media packets to spread awareness messaging and prevention messaging to numerous audiences, guides for connecting with partners and providers toward the common goal of identifying gaps in service areas or prevention needs, and then actionable joint efforts specific to the local department community, again, addressing those wide gaps left by the pandemic and the closures of communities, essentially. We can go to the next slide. So one of the first things on our radar was understanding all of the impacts of those school closures. So the drastic fall in CPS referrals that came with the closures and with communities essentially shutting down. We immediately partnered with BDOE at the state level to develop resources, strategies, and action items for communicating out with school personnel, families, and communities to address the concerns brought along with the drop in referrals. We created joint messaging to ensure that mandates within the Every Student Succeeds Act, or ESSA, were still able to uphold the rights of children and youth to maintain school stability. And we planned for joint agency support resources, including a webinar targeting prevention for school staff, which was designed by Families Forward and reviewed by BDSS. Now we continue that partnership and collaboration regularly, continuing to engage at our state level and regional levels to be able to assess new needs as they come along and other opportunities to partner. We can go to the next slide. So this slide really provides kind of a trajectory visually of how our cross-sector multi-agency collaboration efforts produce resources to directly support the safety and well-being of Virginia's children and families. This was made possible by leveraging our own team resources and ability to adaptively repurpose and convert our structure into more agile functioning in crisis, and through identifying the unique abilities, resources, and social capital of the partners we so value, nonprofits, private providers, state and community agencies included, and we all work toward common goals, supporting our children and families' safety and well-being and ability to thrive even in the hardest times. So we had the flyers for prevention early on. We had social media and hashtag campaigns, the older youth campaign that I'll speak to in a couple of slides. Our prevention PSA, which we actually just found out this week aired over 3,000 times. And then the prevention toolkit, and really, most importantly, what culminated from this crisis for us was really strengthened partnerships that continue to be so mutually beneficial, even as our goals may shift toward less crisis-oriented tasks. We can go to the next slide. So again, Families Forward and VDOE collaborated to create these, and that collaboration was born of our COVID-catalyzed partner meetings that began in, I think, April. The second flyer we created with consultation and input from multiple partners. The second flyer was also translated into Spanish and sent out via regional offices to our local departments and shared with our partners. We can go to the next slide. So we're really excited about this particular collaboration, which culminated in a series of social media campaign materials, which were designed and informed by youth voice and lived experience voice. Again, through our partnerships with other public agencies and private and nonprofit partners, our public affairs and project team were able to develop these and other messages with multiple youth service providers as well, including Project Life, and some other partners who interface with our youth who have had lived experience within the child welfare system. In terms of this campaign, one youth in particular, we got great feedback from. She was so excited to see that her wording verbatim had been used in the post and had actually developed a hashtag that was then spread across the state. So it was a very satisfying experience and, clearly served to spread the prevention messaging to a target audience that may not have been focused on entirely before in terms of prevention messaging. And we can go to the next slide. Here are more examples of the youth collaboration to provide statewide messaging, plus the prevention example of a family violence and prevention campaign collaboration. The post on the left is the older youth campaign. The post on the right was developed as part of the family violence and prevention messaging campaign. So this is all really to show what can happen when we realized our strengths and our weaknesses, right? Identifying who our partners are that bring different strengths and who can draw on their own unique benefits from partnering with us as well. Symbiotic relationship, really, I think many of them have been formed through this experience. So speaking, again, to our partnerships, I will turn this back over to April with Henry Martinsville to talk more about the DSS perspective brought on by COVID.
Okay, so our local CPMT and FAP teams have really come together to figure out the new normalcy of COVID-19. So currently, both our CPMT and our FAPT meetings are being held via Google Meet's virtual platform. Getting there wasn't so easy. We really initially transitioning into the virtual world. There were some community partners that, refused to use Google Meets, or they said no to the Zoom meetings, using Zoom in this platform. So we really had to come together and discuss how do we meet security needs for everybody. So, we, as I stated, I mean, it wasn't an easy process, but, obviously with us coming together, the CPMT really, really took everyone's needs at hand and really tried to figure out what we needed to put in place to meet everyone's needs. So after many discussions and meetings, it ultimately was decided that the Google Meets would be the best platform for the locality. And of course, that is that no personal identifying information would be shared during that platform. So But we will really, you know, I will praise our CPMT members, our FAP members, that we really did come together, you know, for the better of the families that we serve, and was able to put that together. And I will say that since we have been doing our meetings virtually, I mean, it really has increased our family participation. Our families are participating more in our meetings virtually. We also are having the voice of the youth at the table more often, which is great. So, you know, after some difficult discussions, and, you know, we really have come together as a community, and it has been successful with our locality in doing our meetings virtually. And just moving on to the next slide, you know, we can virtually do anything when we work together. As I stated previously, our FAPT and CPMT members have really come together. You know, obviously the focus is getting the appropriate services in place for the families and kids that we serve. A lot of our service providers are utilizing the telehealth that is allowing them to continue to provide counseling and therapy services to their families and kids. Also, we are being connected through email, phone, and obviously the virtual meetings. As far as our courts are having hearings some are having hearings in person, and some are virtually. So that seems to be going well as well. Moving on to the next slide, this is a picture of us. We had hosted a foster parent appreciation parade. This is some of the staff that came together and volunteered their time and made some amazing signs that you can see. So what we did was the community actually donated some prizes for us to put together some goodie baskets. This was in honor of appreciating our foster parents. So the community did come together and donate, so where we were able to put some goodie baskets together. And we also got donations and was able to get gift certificates for the youth as well, and the kids. So we basically did just foster parent appreciation parade, drive-by, however you want to say that, where the foster parents just kind of drove through. We cheered them on and just really showed our appreciation for, you know, if it weren't for them, we couldn't do the work that we do with our foster children. Also, we would not have been able to put this event together had it not been for the support of our community. So we do appreciate the support that we do have within our locality. And then there also for some virtual training opportunities, as you can see, of course, again, a picture just of some of our staff and the signs that they made. Houses become homes because of your yes, and thanks isn't enough. And that truly is true when it comes to our foster families. But the virtual, we have to put some additional supports in place for our families, our foster families. We have created a closed Facebook group This has given us an opportunity to quickly share resources. Also, it's been able to keep the foster parents connected during this time. We are also joined for any new foster families coming in. We are doing online pride trainings. So we currently have one going on right now, and we're hoping to recruit some families through that. So this also has opened up some opportunities for us to do some online training as well.
All right. Well, thank you, April, for going over that and those details. What we'd like to do is we have 2 questions we would like to pose to you, and also get ready to take your questions, because that pretty much brings us to the end of the formal presentation. But what we're hoping is that you could type in the chat about how you see the virtual environment and activities that we're talking about impacting how we work together, and what would be different. So we're thinking specifically around our interaction between us as the department and service providers, and how we're able to do that really to make sure we're meeting the needs of the children and families that we're serving. And we're talking about service as well as all of the components that go into supporting our service array in terms of going to FAPT, the CPMT CSA process that April was talking about, going to FAPT, and then also just being able to have our multidisciplinary meetings and our regular conversations. And we do know that some of the complications are that some of the platforms are not secure. And when we're talking about children and families, we need to make sure that we're being HIPAA and PII compliant, which has been one of the hurdles that we hope we've overcome at this point. So so we will go ahead and get to some of your questions here. Between Bethany, April, and I, we are going to do our best to respond at both the state and the local level. So one of the questions is about is the protocol the same for reporting observances of possible abuse and neglect in a virtual setting? Well, we want it to be as much of the same as possible. And so one of the things that we've done in April, I certainly invite you to talk about this in more detail. But what we were able to do at this state, and one of the slides I showed, which you weren't really able to see it, is we created guides on how workers would be able to do some of those virtual visits with the doxy.me. And one of the things is that we put out some information on how workers would ask parents and ask the youth that they're working with to kind of walk through the house, to be able to see the environment when they're talking to the children and youth. A lot of the families have agreed that the children can be on the camera you see in that environment. So we're certainly doing everything we can to ensure safety of the child in the home if it is not safe for the worker to physically go out there and observe the inside of the home environment. So with that, April, I'll turn it over to you to see if there's anything that you would like to add from a direct practice perspective.
The only thing that I would add is, as I stated before, we really have tried to, our director has done a great job with really putting safety first when it comes to us going out into the field. We have provided the PPE for the staff. We have purchased contactless thermometers to where now that we are transitioning into, going out into the field more with our families. So, we are screening the families prior to us going out into the field. We are calling our families, walking them through the COVID-19 screening tool, looking at what, if it's making a determination if it's, safe for us as a staff, as well as the family, to to make that face-to-face contact, because we do think that that is important to continue to have that face-to-face contact. But we also want our staff to be safe, but we also want our families to be safe. So we have put in place, if there's no yes answers to the screening tool, then we are making face-to-face contacts. At this time, of course, the colder it gets, we might have to make some changes, but at this time we are trying to visit with the families outside of the home, but we also know that that's not always realistic. So we do, try to do what's best for the family as well. But we are, requiring that everyone wear a mask. We are social distancing, and everyone's temperatures are being taken prior to the visit, just to make sure that their safety is first.
Great, thank you, April. That's helpful to get that perspective. And also in terms of reporting, mandated reporting in general, I know Bethany talked quite a bit about the work we've done with the schools, but we've also worked with a lot of doctors and hospital staff around the reporting and things that they can look at a little differently, because children were continuing for the most part to be able to go to the doctor's office once we kind of got out of that March, April kind of time frame. And so we've messaged out to the medical community and things like that. So we have continued to work with the folks who are reporting. The majority of our reports do come from law enforcement and then from hospitals. And so we've continued to maintain those strong connections with those entities around reporting protocols. So another question that we have is, how can we better address the lack of visual participation in FAP meetings? It seems everyone is just on by voice. We find that some members turn their videos on and off and are not really engaged, and some family members are only able to call in without the capacity to get on video. So there's quite a bit in there. So I can answer it in three different ways. I think this is a really, really important question, because this gets to how does this impact our work as we move forward? And we know that the intent of our FAP teams are to allow for that multidisciplinary approach and to be able to make sure that the family's needs are being addressed and looked at from all of our system perspectives. And so it is very important for us to be able to continue to have those meetings and have that part of our best case practice. In terms of the workforce, you heard April talk about their telework guidelines and responsibilities. So as localities are moving to securing what teleworking would look like for them moving forward, there are guidelines put in place, such as workers and staff should be on camera at all times whenever possible. You see Bethany and I on the camera. I think I'm just going to open a regular Zoom meeting all day long and people can just come in and out like they would of my office when I was at work. So this might be one of these virtual jump in and out kind of things, because we're always on camera. I know April's having issues on her end with her camera. We have purchased cameras for everyone at the state and the regional offices because our computers did not come equipped with cameras. So we put that in place. We also have provided guidance for folks to be able to use their cell phones as cameras, and I know localities are working on that as well. So we do encourage teams as they're coming together virtually to establish protocols and set up kind of the rules of the meeting per se. And so that might be something that folks consider, and that at least for the professionals. And I know that's happening in court hearings as well. In terms of the engagement, one of the things we try to do is, and you can see it, we're calling it collective thinking. We're trying to do engagement in two ways. So there's one thing about a presentation, there's another thing about being engaged in the meeting. So one of the things we've done at the state is for our staff and for other folks, when we come on meetings and establish those and establish our agreements in that we'll be present, we'll be on video. What we do is we encourage folks to type into the chat and to acknowledge non-verbally, shaking your head, agreeing, just like you would in a meeting, that you're involved in that meeting. So we kind of set up some of the agreements that we would do of how we would be a good virtual participant, as well as attending to the hosting of that virtual meeting, whatever that may be. In terms of the families, so one of the things is, we're really excited, and we've talked about the DoxyMe and being able to have that as an option to talk with families and engage with families. The concern with that is the bandwidth in Virginia, which unfortunately we have no control over or nothing to do with. And so I know that that's stuff that a lot of the legislators and people are taking up. And have been for years, but certainly it's become a front and center issue. And so April is actually turning the slides and showing the slides for me, because I live in the country and I have very poor bandwidth, and so therefore I can't be on video and also share my screen. So I hear this with a lot of folks. And so with the families, that can be difficult because they'll have to be on the phone. A lot of families do not have bandwidth, or they do not have cameras. And that's one of the things that we're trying to look at from an agency perspective. And we invite the whole child welfare community, all of you who are on this call, to help us solution that. In that, how can we help families be able to have access to the technology they need? The schools have done a fantastic job. And a lot of the children now do have computers and iPads and things like that do have cameras that we are able to use and access. Schools have provided hotspot areas, and schools have provided hotspots actually to some of the children who are in zones that traditionally have bad bandwidth. But there's just some parts of Virginia where bandwidth is just still too difficult. So we will continue to work on that, but we invite you to help us solution that and to join in with our partners at the Department of Education on how we can better access internet and bandwidth to support families in being fully engaged. And Bethany, somebody is asking about the prevention webinar. Is that available?
Yeah, so we can, I know there are several links out there. I think the VDOE website currently hosts the prevention webinar. It's really geared towards school personnel. So thinking of, counselors, teachers, anybody who would be typically within a physical school space. But I know for sure it's on the VDOE website, and I believe in a couple other locations as well.
All right, I'm not sure. I'm checking in to see if there are any other questions that are coming in. I think we have another question if we want to switch to the next slide. And we're bringing you these questions because we really see this as an opportunity for us to collaborate with you. And you have a lot of resources, and you're out in the field as much as the local departments, and so we're really looking forward to talking about what success would look like as we move forward over the next year. And we're talking about looking at the safety, permanency, and well-being of children, and how do we really come together to do this in the virtual environment. You heard April talking about putting in the park and being able to have the ability to supervise the visits. One of the areas that we really would like to do a call for action on and ask for ideas on how we can better solution is how we can ensure that children and families are able to visit together in person whenever safe and whenever possible. Lots of children have been visiting, who are in foster care, have been visiting their families virtually. Although that's great, and it actually has increased a lot of times the amount of time they see their families, it's not a replacement for that face-to-face time. And so one of the difficulties are that the visits need to happen outside, or they need to happen outside of the local agency. And so we're struggling with being able to have those locations for the visits, and then folks to help supervise and support those visits. And so parks and all of that have been identified. April talked about that. I know Fredericksburg, lots of different localities are using their outdoor facilities. However, as we move into the winter and it gets colder, we're going to have a lot more limited options for visits. And so that would be something that would be great if we could collectively come together as a child welfare community to be able to offer that component to families. So we have another question. As mandated reporters, are the protocols the same? So mandated reporting protocols have not changed. If you're a mandated reporter, you obviously would be following the mandated reporter protocols. What's changed is the amount of exposure mandated reporters are having to children. And so the more children are in their own environments and not able to be out in public community settings, the less mandated reporters have access to seeing the health and well-being of children. And Bethany talked quite a bit about the outreach that we're doing and the outreach that specific localities are doing and the creative ways they're doing that with the Nextdoor apps and all those different things to help educate folks who traditionally wouldn't have been the mandated reporters. But that information hasn't changed. I will tell you, I will give you a glimpse into what's coming. We're really happy to report that our mandated reporter website is going to be up and running. And so you'll be getting information about that. And so we'll actually have a website where instead of calling into the hotline, you can report straight through a website and be able to get that information in. So we're trying to make it as nimble and flexible as possible for folks to report. Another question is wondering about community-based prevention services and how COVID has impacted planning for Family First implementation. So COVID has impacted Family First implementation. So one of those ways is in the fiscal components of Family First. So because of COVID, I think all of us know that the funding that was put forward through the General Assembly was put on hold for a bit because the funding was being reserved to manage all the emergency response in Virginia that came up as a result of COVID. And so as the General Assembly is moving forward, they're looking at the funds that are available to fund the prevention service part of Family First. And the prevention service part of Family First is funding the evidence-based services that would address preventing children from coming into foster care. And so they're very specific services that we're talking about. So COVID has impacted that. Our Family First implementation was scheduled to kick off on July 1 of 2020. And now we're looking at that actually kicking off July of 2021. So it certainly has pushed it back a bit, but we will be on track to be able to deliver those services. But it definitely did impact it. Okay, let's see. There's questions about inability to do as much in-person work will result in delayed opportunities for reunification. That is a very real concern, and why I was bringing up the importance of needing to make sure that we can come together as a child welfare community to make sure that the children are able to visit their parents and able to visit their siblings and their extended family. It's very important for that to take place so that we can keep on track with the reunification goals for the children and the families. And so one of the things that we've done is we're working very closely with the courts. We're working with our state level courts, and then local departments are working with their courts. A lot of the dockets did get backed up because of COVID, but the courts have been pretty nimble in doing virtual court hearings and putting safety guidelines in. And so we are looking at being able to get back on track with those court hearings. But that is definitely something that we're looking at. It has not delayed the opportunity for trial home visits. As a matter of fact, there's more trial home visits taking place now than there were before, because families were available and service providers are available to support those services. So that's something that's good news, but that's something that we just want to continue to look at. Let's see. Maybe April, you can help with this one. Is there, or maybe someone, I'm not sure, is there an Instagram or Facebook page that keep us up with these updates? I think you mentioned this, but may have missed something. So Bethany and April, I know Bethany, we have websites and different things. So I'm going to turn this over to Bethany for the state, and then April talked about what they're doing, at least in her locality with Facebook.
Yeah, so we have the VDSS public page and Twitter account, and so all of that messaging, the prevention messaging, the older youth campaigns, things like that would come through those two platforms from the state level. And then the Facebook page reference, I think that April was speaking to, was the closed Facebook account or platform that the agency, Henry Martinsville, had started. Kind of, catalyzed by COVID, potentially for their staff. So I'll hand it back to April to kind of talk a little bit more about that.
Yes, so we did, as I stated earlier, we had we started the closed Facebook page. And the reason we started that is because we really wanted to make sure that our foster families stayed connected. But outside of that, we do not have a agency page, public page as of right now. The only thing that we do have is the closed page for, we do have one for foster parents, and then we also have one for our staff where we can continue to send pictures. We socialize, just kind of to keep that connection. But as far as a public page, we do not have that as of right now.
Okay. Our other question, are schools being used to supervise visits? So that is a really good suggestion. We've talked about this. Schools have traditionally not been used in this capacity. Schools are not used as visitation centers. However, we have posed this question. This would have to be something that would need to be negotiated at a local level between local departments and the schools, and ideally the full child welfare community. Right now, the schools have obviously been inundated and overloaded with making accommodations for how they would best be able to serve children in a safe environment. And so that's something that we could definitely support. But we would have to look at that at the local level and be aware of where the schools are and what they're working through, which I think we all see on a regular basis. But having that physical environment certainly is a good suggestion and something that we can support following up on. All right, and I can see that Bethany is going to share out some of the Facebook and Twitter links for folks to be able to have access to. All right, I'm not sure if there are any other questions or just any other feedback in general. All right, so Zandra, should we turn it back over to you?
That sounds great. Hello?
We can hear you.
Okay, well, thank you so much, Kristen, Bethany, and April. It has definitely been a pleasure. I really enjoyed the question and answer approach. That was a little different, and you all were able to respond and give great information to the participants and attendees in our virtual land. It's exciting to see the innovations and the redirects that particularly our partners with social services as well as service providers, all the wonderful, incredible things that you've been able to sort of, I think someone refers to it, turn on a swivel that we've all had to do during this pandemic. I'd like, if there's anything else you'd like to say, the questions particularly about the involvement of the families and perhaps continued use of these virtual means beyond, when we are beyond COVID-19, I think hold a great deal of relevance and import, particularly for those families. We even talked about it with the FAP members. We talk about parent reps and families being able to participate in these meetings. It would be great. I think we've all found that it'll be great to explore how we can continue to merge our different technologies, to help improve outcomes for all of our families and children. So if there is nothing else, what I'd like to do is give a few updates. Thank you again. And I'll give a few updates and a few points of reference as we continue our day. As we said, all of our sessions will be recorded and available. Hopefully anyone who has needed closed captioning has been able to find that and use that without any problem. I understand that we have our own executive director check that out. So I'm glad that that has been available. You will hear more after our break when we reconvene at 11 o'clock. You'll hear more about today's giveaways. And you will also hear the secret word. I'm not going to disclose that right now. That will be the privilege of Executive Director Reiner. But thank you all again so much for the wealth of information, for your wonderful spirits and the commitment to collaboration and serving the children and families wherever they are in the Commonwealth. So with that, we will see you all back here at 11 o'clock. Thank you.
Good morning, everyone. Good morning. The big hand is on the 12 and the little hand is on the 11. And that means it's time for the last session of our 2020 virtual CSA conference. You've heard so far how in different parts of our world, things are different. The new normal, they like to say, in schools, in child welfare, and in our last session today in behavioral health. Who would have thought 7 or 8 months ago that you would say, oh, there's my therapist in my iPhone? I don't think anyone would have thought that would have happened, but it has. And so our last session today will give us an opportunity to hear how the ground has shifted for our behavioral health system as it strives to meet the needs of children and families, both through the pandemic and beyond. Many of you know that the World Series just ended. And if you didn't, sorry, but it did. And I will have to just take a moment to say that my favorite team, that would be the New York Mets, right? We're not in the World Series and are perhaps the worst team in Major League Baseball, but I am not a fair weather fan. Go Mets. But to further that metaphor, today we have an all-star team of presenters to close our conference. And you got their bios in the program. I will have to say they all come from the world of clinical training, and maybe that's why they wish to maintain their anonymity in providing, instead of photographs, little avatars in the program. And so our first presenter, and if you've looked at her avatar, it looks oh so much like Where in the World is Carmen Sandiego, if you remember that program. But Alyssa Ward, Dr. Alyssa Ward is with us. And Alyssa is the Behavioral Health Clinical Director at the Department of Medical Assistant Services, or DMAS. And among the many other things that she's responsible for there, Alyssa is what I like to call at the tip of the spear of Virginia's efforts at behavioral health enhancement to bring new and oh so necessary evidence-based and effective services to the many hundreds of thousands of Medicaid members across the state. And I would have to, just on a personal basis, I've been doing this a while, and Medicaid has traditionally been an adult-focused system. There's probably more adults in need. But throughout this work at redesigning, and enhancing the behavioral health system under Alyssa's leadership, the needs of children and their families have been truly at the forefront of their efforts. And it's greatly appreciated for those of us who are most concerned about children. And so I want to thank Alyssa for being here and for being such a great colleague in state government and just generally. Joining Alyssa is Natalie Elliott. And Natalie is the first of our two partners from the private sector that have joined us. And she's Senior Director of Program Development at Intercept Health. And Intercept is a large statewide provider of behavioral health care services across the Commonwealth. And for as long as I know, they've been a leader in developing and implementing innovative services, often for the very most challenging youth that we face. And Natalie is always coming to me and says, look, if we could put this new program together, would CSA be willing to throw a few dollars at it? Because she wants to find every possible way to get the best and newest and best services to the children and families they serve. So she's been in the private sector a long time, but she's not a stranger to CSA, and was previously a CSA coordinator in Roanoke, and continues to serve on their FAP team right now. So welcome, Natalie. And finally, Stefan Stark, who's the Vice President of Community Relations at NCG Care. You guys change your names a lot, so I have to keep up with that, but it is NCG Care, which is also a big statewide provider of community-based services for all kinds of folks, and they have a particular strength in serving children through a whole array of services, including applied behavior analysis, and they're one of the bigger providers of MST in the state. And Stefan grew up in the suburbs of New York, which is probably one reason I like him so much. Although he does say New Jersey, and I'm from Queens. But you know, there's something about that New York vibe that I think makes us compadres, Stefan. So I want to thank Stefan for joining us as well. I can tell you that when we were putting this session together, and I reached out to Alyssa and Natalie and Stefan, and said, you know, would you be willing to step into the virtual world with us and deliver this training to what you may not know is I think was yesterday, over 1,000 participants. They didn't even skip a beat in saying, yes, of course, how can we help? And that's why they're such valuable partners, all of them, to the work we do in CSA and to the efforts we are consistently trying to make to improve outcomes for kids and families in Virginia. So let me not take up any more of their time. I don't know who's going first, but I'm going to step off, and I'll be back with you later to handle some questions. And thanks again, and take it away, All-Stars.
So thanks so much, Scott. That was nice. Because of us being relative geographical compadres, I will not talk about the Mets. I will not bring up Bill Buckner. I will do none of that. The Mets will rise again one day, I'm sure. With that, let me share my screen. And here we are. So as Scott said, the three of us, Natalie, Dr. Ward, and I, we have been asked to talk about behavioral health in the era of COVID-19. The whole conference has been obviously enmeshed in that idea, talking about it from different perspectives. And we were honored to be asked to talk about it, not only from a private perspective, but from a public perspective, from a practical perspective, from a policy perspective. What have we been through? What is it? What has been the impact? Where are we today? And where will this take us? And the three of us have been working together over the last month to try to address this. And we think we've put together a fairly succinct and hopefully meaningful presentation for all of you. Ultimately, as dark as the times have been in many ways, we really wanted to reframe it and talk about the positivity as well, not to deny the negatives, but to discuss and to embrace the positives and to bring hope to our future, because the hope is great, the hope is vast, and it's very much tangible. With that, excuse me, because I need to operate a few things. Scott mentioned that we had our Bitmojis. I can't remember if this was Dr. Ward's idea, Alyssa's idea, but we thought it was wonderful to, especially since we are in a digital age, it's not so much that we are shy of our personal appearances, but why not embrace the digital and go with some Bitmojis? So Natalie, I don't know if you want to talk a little bit at all about your passion for where we are in human services and what this has meant to you, but we thought we'd talk a little bit about that and then move on to our presentation.
Sure, thanks so much. And I want to thank Stefan, because Stefan actually helped me with my Bitmoji. He also provided some of the makeup a little bit as well, because I think the alternative is not as great. But thank you to Scott and the team at OCS for the invitation to present. And I'm very blessed to be with Stefan and Alyssa to present. They're absolutely amazing. And I think you guys will absolutely enjoy the presentation, because we will also be funny. And we just fully prepared for that for you. So it's informative. It's going to be a really good time. And we're going to encourage you guys to use the chat function, because I typically can't remember, my questions till the end. So if you want to throw in, you're going to hear me, especially talking about throw in ideas into the chat function, and we'll be speaking about them or calling them out as we go. I think that's really important. And then, I think COVID-19 hit, and it definitely hit really fast and really quickly when it did. And so I can tell you from a service provider standpoint, even personally, I mean, we had to make major changes really, really fast. And it just demonstrates all providers and folks, everybody in the systems, resiliency and being able to come together and make an impact for our clients. That's his number one. We had to make an impact for our clients. And so Intercept, it definitely impacted our full continuum. And we'll be hitting on those areas, but especially the pandemic and telehealth especially has allowed for a lot of silver linings. And so we found that in the community homes, No one would have thought about using video necessarily in a community home setting, for example. We've been doing community homes for 25 years. We use video every day now, every day, to connect our children with their families, to connect with family therapy. We're using it in so many different ways, actually even to be able to connect our children with their school and with classmates, because those connections and normalcy is so important, and we're all trying to find what the new normal is. So we're really excited to be a part of this, and I will pass it over to Dr. Ward.
Thank you, Natalie. Thank you, Stefan. When we were thinking through how to kick this off for everyone, we thought that as Stefan and Natalie have started to do, that it would be helpful just to orient you to our own journeys, finding the light in this darkness. And we know that you all have been out there working and functioning in ways with your families and with those that you serve that you never imagined before. And certainly, if I think about starting off in community mental health at the start of my career, I, first of all, never imagined that I would be working for Medicaid. But it is a role that in the last 2 years, as I've grown into this role, it's certainly brought an incredible amount of meaning to my life, and a lot of full circle meaning for me as a kid who grew up as a Medicaid member. And so really, as I was starting to get settled at Medicaid and make the transition from being someone who was a full-time clinical provider as a child psychologist at Richmond Children's Hospital at VCU, this happened. And I will never forget that day in March when the public health emergency was declared, and what that was like kind of as a decision maker, as a policy maker, the types of positions that we were all in, where we really had to bond together. And we're going to talk a bit about that today as one of the lights that has shown through this process. When things started to fall apart, we didn't fall apart in terms of our collaborations. I actually feel like this helped bond together many of us who work across the different state agencies, including really remarkable collaboration from OCS with DMAS and DSS and others, and really appreciate everything done in that collaboration with me during this time, but also with providers. And we've had to make really hard decisions and have tried to do the best we could with really minimal information and be as transparent as we could with folks going along. And we're going to talk a little bit about what that has resulted in and where we hope to take that in the future today.
Yeah, thanks so much, Alyssa. Finally, and before we begin, like Natalie, I've been in this field a very long time. I don't like to talk about it because I came into this field as kind of a young sprout, eager to learn, and now I feel like one of the elders who's graying and losing his hair. I'm certainly the oldest one on this panel, which is sad and unfortunate. I've seen a lot of change in human services. I've been a part of a lot of change in human services, and we've seen issues, we've seen catastrophes, we've seen local and national traumas. Never have we had an experience that has been so collectively traumatizing, even going back to 9/11. And that's not to diminish, of course, 9/11, but in terms of an immediate and long-standing collective impact, it's truly been remarkable. And it's left us with trauma. It's left us with questions and confusion, with anxieties. And it's left us trying to function in many ways, flying a plane while we've been building it, which is completely natural. Politicians like to blame each other for all of this, but the reality is this would have been a problem no matter what. No one could ever be prepared for what we what we've been dealing with. And what's nice, and what I hope you will see, and what I certainly have seen, is excuse me, a tremendous collaboration between providers, between the public, between all stakeholders, in trying to address the everyday needs and the expansive needs of our communities. And that, I think, is the message, hopefully, that will come through, and that is the most important. And perhaps, and hopefully, the greatest hope is that we can kind of take these lessons and take this collaborative spirit beyond, when we do revert to the mean, when we do achieve normalcy, which of course we will. What will we take from this, and how much better off will we be? So this is an exciting time, I think, for all of us, and one that in many ways is very energizing if we reframe our focus. With that, Alyssa, do you want to talk about how we got here?
Sure. And, this slide can kind of set us up for this, but I welcome you. You can switch off the slide, because I think the audience can't see our faces. I think that's right, as the slides are up. But so as you take this in, the slide initially, what this is meant to visually represent is, in terms of the system and Medicaid perspective, Scott teed this off a bit in his introductions. Oh, we're all visible with the slide. Okay, great. Technology. We were at the precipice of a really exciting time, COVID-19. There was remarkable change happening that had been building over a period of many years, and efforts across stakeholder bodies and agencies to really improve the quality and robustness of the types of behavioral health services that we have available for kids and families in Virginia. And so that first block you see here is what we call the alignment wheel, but it is representative of all these different kind of pieces of the puzzle in the wheel of motion forward in the evolution of behavioral health services. And that includes at the center our proposal for behavioral health enhancement in Medicaid, which was based off of a really high level vision, a proposal for a continuum of services that would really put the emphasis on prevention, on early intervention, on consumer orientation, really on member orientation, and on use of evidence-based practices, and using a trauma-informed lens in terms of implementing those across the system. And we had initial approval in the approved budget prior to COVID to move forward with a set of 6 critical services that were intended to directly address the state psychiatric bed crisis, but also to bring into alignment some of the things that are benefit with evidence-based services that were going to come online with the Family First Prevention Services Act, including new rates for multi-systemic therapy and functional family therapy. And we were all very excited to move forward with this process in a stepwise fashion, and then COVID interceded. And I'm happy to report today that, as far as things sit right now, in the conference report and the budget that's awaiting signature, behavioral health enhancement has been reallotted, and we do have funding to move forward with that process. But, for the last 6 months, everything has been up in the air, and we haven't really known where we were going to be able to move forward with those services and with that proposal. So, at this high system level, we had all this momentum forward and all this collaboration. I had this great introduction to so many stakeholders through going out and talking about this proposal and understanding the needs of the system, and really hearing from stakeholders about what was going to be necessary to make meaningful change. So the future is coming into a little more clarity now that we know that, at least for behavioral health enhancement, that we are potentially, should the governor sign the budget, including everything, that we will be able to move forward with that. But we are very sensitive and aware to the fact that everything has changed. The system has changed. Our members' needs are changing as a reflection of this collective experience. Our provider workforce has been deeply affected and changed. Services have turned on their heads. We thought about telehealth within some of those services, but telehealth delivery has completely changed. And so now as we move forward and think about the description of how to deliver these potentially new enhanced services, we need to go back to the drawing board about how telehealth would be inserted into the formal policies of these services. So it's changed everything. And more than ever, we need to work together to understand how to make it a meaningful implementation plan.
Thank you, Alyssa. So what have been the impacts of COVID? Much of this, this will not be new information, but it is, there are some topics that we need to think on, and it's worth discussing. So who has not been impacted by the pandemic, right? Everybody. I read an article early on. I don't know if it was accurate. It's hard to know if it was accurate, but it was mind-blowing, and it was about someone in a primitive tribe in the Amazon in South America. One of these tribesmen apparently tested positive for COVID, and I think this was back in April when it was happening, when things were really not well understood. And I remember reading this article. Now again, I don't know if it was valid ultimately, but it was mind-blowing. How could this virus spread to these kinds of places? How does this happen? But it truly was a worldwide pandemic, and it has impacted every single person, certainly in our country and in our state, regardless of demographic. We've all been impacted more or less. It's affected everyone. Think about all the ways that we've been impacted, all the challenges, economic, emotional, practical. Life has become challenging, to say the least. Now, think about how the pandemic has impacted the disenfranchised among us, the socioeconomically disadvantaged, those with less education, less access to the internet and information, those with medical, psychological, developmental, intellectual, and maturational hurdles, namely those we serve in CSA. Imagine both the very real and the perceived impact of this pandemic on the most vulnerable in Virginia. We have economic stress. So money is incredibly important. It may be a secondary reinforcer from a behavioral standpoint, but we all recognize that our families, like each of us, cannot work on their issues when they have more practical matters to consider, such as putting food on the table. Job loss has been staggering. So in February, prior to the pandemic, the month before, we had an unemployment rate that was relatively unprecedented, 3.8% across the nation. But 3 months later in May, that rose to 13%, and 13% is pretty conservative because we had a lot of difficulties in really assessing and validating that information. There were a lot of hurdles that were thrown in there, a lot of monkey wrenches. So experts believe it was really as high as 16%, which is fascinating because it was predicted to go as high as 20 or 25%. It's a very meaningful loss in jobs. Unfortunately, there was a disproportionate impact on job loss. It affected women and minorities more than it did men or Caucasian men. As an example, close to 12% of men lost work, while over 14% of women. And while 12% of Caucasian women became unemployed, over 17% of Black women were became unemployed. That's what the rate rose to. Less than 10% of white men became unemployed, where almost 16% of Black men. And Hispanic females, their unemployment jumped to almost 20%. So lower wage jobs also suffered, to include those associated with restaurants. Furthermore, innovations, which can often be associated as good, they have exacerbated job loss because within these sectors, because this is not likely to return too quickly, because innovations lead to greater efficiencies, which means ultimately less labor or wage opportunities. Those with more education suffered less job loss as well. So if you want a good example of the economic impact of the pandemic, just think back to the shortage of toilet paper, right? Who remembers that? It still may be happening in some parts of the country, thankfully not in my household. Imagine the wealthiest country in the history of the earth cannot address a supply chain shortage of toilet paper. Who would have ever thought that? It's pretty crazy. There was even food rationing. They said it wouldn't happen, but any of you who remember going into the supermarkets during especially the first, say, 4 months of the pandemic, there was a lot of empty shelves. It wasn't just toilet paper and cleaning supplies. There were food shortages. I remember, interestingly, I couldn't find Worcestershire sauce. I needed Worcestershire, and it was out. There were tons of things that were out, and you didn't really know when or how you would find certain things. I remember reading about this in communist Russia and the Soviet Union, that this is the way it was. Who would have thought that America could look like that? So then we have the fear of the illness. I have a friend who's a physical therapist who's been shopping for months, shopping for a previous elderly patient and her husband because they were terrified to leave the house. They were taking their non-perishables and leaving them in the garage for 3 days, wiping down everything with bleach. The virus has made us in many ways somewhat paranoid. And it's not all paranoia, but our anxieties have in many ways gotten the best of us. There's a very real and practical sense of fear. How bad is it out there? Will I or those I love get the virus? What will happen to us? And this is aggravated by the lack of consistent and objective information coming from the government and the press. Couple that with the fact that the families we serve only have so much access to or engagement with the news or other forms of information. So there's a lot of isolation that we ourselves can't even relate to as well. What about the impact of children, on children, the fears of children? I grew up in the 80s when nuclear proliferation was the concern of the day. I remember watching the movie The Day After in 1985. Those of you who've seen it, it's a pretty disturbing film about the potential for nuclear war. And after I watched it, I remember, I think I was in 8th grade when that happened. And I, like many others, felt that nuclear war was imminent. That was the anxiety, the collective anxiety of the time. It actually wasn't imminent, but it's how I saw the world. As a child, I couldn't process through that. I wasn't abstract enough. I didn't have enough insight or knowledge. And that was before 24-hour news cycling. Now imagine the anxieties that children have about the world. Just turn on the TV and you'd think that everything is ending. We have bereavement and grief. How many of us know someone who's either succumbed to COVID or is now bereaved due to COVID? About 1 in 1,500 statistically have died from the pandemic. That ratio increases among minorities and of course the elderly, but it also does not account for deaths indirectly associated with the virus, to include those who've not sought proactive or necessary medical treatment. Death by despair, you've heard that term. That includes suicide, overdose, heartbreak. The full impact on morbidity and death may never be known, certainly not for some time. We've seen disrupted grief processes. I remember seeing news stories, especially in New York, about those with serious COVID complications being sent to hospitals and being unable to see loved ones as they entered the stages of death. Now, those of us who've unfortunately lost loved ones precipitously in our lives, we can relate somewhat, but this phenomenon was much more traumatic. We weren't simply hearing after the fact about loved ones who've perished. We were watching our loved ones go to the ICUs, knowing the probability of their demise and not being able to comfort them or say goodbye. The horror of that is tremendously palpable, and the trauma is far-reaching. Mourning rituals are important for us as humans so that we may process significant loss. And when these rituals are disrupted, to include being able to host a funeral, the trauma has no clear path for abatement and healing. We've lost routines. Has anyone other than me felt that the last 7 months have been one long day? And that's what it feels like. It feels like one long day. It's like the movie Groundhog Day. I feel like I'm in a kind of a recurring dream. It's not quite real. It's somewhat intangible. It's moving without really a sense of time. And the apocalyptic nature of things only adds to this surreal feeling, but it has much to do with not having a routine. Things are starting to change a little bit now, thankfully. There's a little bit of a reversion to the mean. We're starting to habituate to the new normal. But for the most part, what we knew is no longer, even if it's temporary. So how is this for a standard or a collective routine that we can relate to? We get up and get ready every day, right? We send the kids to school, or we ourselves go to work. Our kids engage in after-school activities and sports, and we often take them to practice. At night, we process and we discuss our diverse, disparate events of the day, right, over dinner or otherwise, and we go to bed. That's our work week. It's a typical work week. On the weekends, we engage in different and often ad hoc routines. There's a lot of activities in the community. Our days, therefore, our sense of times are structured by routines. But where did these structures go? For the last 7 months, more or less, we've had the same monotonous routine. Get up, stay home, work and play in the house, and discuss the same activities each and every day. And that includes weekends. Every day is kind of the same. So furthermore, the collapse of our general structure and paradigm is cause for great psychological distress. So some of you have heard me talk in the past and present on Joseph Campbell and the power of mythology. We need structures and stories to live by. Our collective story has really been torn apart during COVID. If any of you ever have the chance to read a play or even see the movie Equus, they made it into a movie in the 70s with Richard Burton. It's a wonderful film that talks about the importance of psychological structures and stories to live by. The long and short is it's about a deeply disturbed kid whose worldview is very unhealthy. And the entire play takes place in a psychiatrist's office where this psychiatrist is trying to understand this kid's mythology and what to do about it. And at the end of the play, he is torn with a decision. Do I destroy this child's myth, or do I leave it as unhealthy as it is? And he decides to destroy it. He thinks it's too unhealthy. And it culminates in the child being taken away on a stretcher because he's had a complete psychological break. Regardless of the positive or negative aspects of how we view and relate to the world, it is the structure that allows us to function. And when that's taken away, it causes great distress. So we have to balance demands. We don't have one role anymore, right? We're parents, we're earners, we're teachers, we're therapists, we're prognosticators. My children are going to school, thankfully. I live in Hanover County and I was given that option, but I still have to drop them off and pick them up. That's a stressor. I have to do that during work hours. I can manage it, but what about those of us who have jobs that can't afford that flexibility? What about those of us who have to manage the online education of our children, dealing with their meals, their recess breaks, their constant needs and interruptions? We have to contend with social isolation. So that forces a tremendous change in psychology. If you're on the path to enlightenment, isolation can be helpful if you have the right guide, you have the right focus. But without those tools, we can devolve by being socially isolated. We see it with prisoners when they're in isolation for too long. Depression, anxiety, psychosis, behavioral problems. It can impact our cognition and processing skills, and it can lead to serious substance use. And we're seeing a lot of that. Speaking of substance use and behavioral health exacerbation, the CDC did a poll, this was back in June, and 41% of the respondents reported at least one adverse mental or behavioral health condition associated with the pandemic. That's 2 out of 5 people. 31% had symptoms of anxiety or a depressive disorder. 26% had symptoms of trauma or stressor-related disorders. And over 13% either started or increased their substance use to cope with stress or emotions related to COVID-19. And between you and me, if you poll my social cohort, that number rises significantly. I can tell you a lot of my friends, you know, we have all turned to medicinals to help us. And I think we're all in the same boat on that. So lastly, there's been a decrease in support. And let's talk about that. Isolation takes its toll. We receive much less support now from friends, family, and neighbors. It's just the nature of how it is. Professionals have their place, right? We all have our place in the lives of those we serve, but the real support systems in our lives are our community, permanent supports, natural supports. These just don't exist well during a pandemic. And at least those of us in urban areas who have some financial means, we can benefit from high-speed video calls, but not so much the families we serve. They're truly isolated. And we ourselves as professionals, we're dealing with our own problems, aren't we? Our own changes in routine, our own traumas. We're trying to cope ourselves and don't have the same bandwidth that we used to. We're trying to manage cases virtually, and that's really, really difficult. As hard as we work, we have a lot of roadblocks in our way, and that gets in the way of us trying to care for people.
All right. And so I'm going to talk about the service provider section, and then Dr. Ward's going to follow right behind me on the provider agencies and how it impacts the system. And so the thing that Stefan really talked about impacting our clients, I would say that a number of us can really kind of check the box for ourselves on those elements, because COVID-19 just didn't impact the lower socioeconomic folks, it impacted everybody. And so, but more specifically, kind of talking about what happened to us as providers and as practitioners and clinicians or direct care providers, doesn't matter, to the human service professionals, some of the immediate roadblocks comes to traditional treatment. So, I'm going to go through a little bit of alphabet soup for you. You've got CBT, cognitive-based therapy, you've got dialectical behavioral therapy, DBT, EMDR, MST, FFT, any other T's that we can think of at this moment. All of our modalities are traditionally offered in a face-to-face setting. And so COVID-19 made that awkward because we really couldn't do face-to-face for a window of time. And we're all being asked to wear masks. So we won't even get into mask or no mask, yes mask, don't care mask. But the thing is that if you're covering half of your face, you can't see facial expressions. I mean, I've learned to clearly use my hands still on video. And so this is how I get my steps in on my Fitbit, by artificially moving myself. So it really did make it harder. Conversations, if you think about, think back to March and April when you got on video, because we weren't fluent in video. Like right now we're feeling like, yeah, we got this. But we weren't fluent in video. And so when we started to, all the anxiety related to getting online and so forth, we had to figure out how to have conversations. And it's kind of flat. We're like a business card, we're flat. Somebody used to say, look at, you're just completely flat. You're two-dimensional. Thank God nobody can see the back of my hair. This is where you get. And so they were more abbreviated. And so we had to relearn how to have a relationship with our clients. And so what really felt artificial at first quickly became the norm. And honestly, all of the hiccups actually became blessings because it allowed us to laugh, to be honest with you. We've become more creative. I'm going to tell you, I really didn't know how to use telehealth and all the video stuff. I feel like I'm a touch old on that. But once I got into Teams and I figured out how to change my background, that changed everything for me. It was a total game changer. When I figured out I could upload really cool different backgrounds to see if I could make my coworkers laugh, game changer. And so we figured out as clinicians or practitioners how we can add little things to our meetings. How do we change backgrounds to make it interesting? Are there little things that you can have flying across the screen when you're working with children? Because Lord knows they're hard to keep their attention. They're all squirrels. And so little neat tricks to try to get reconnected and develop relationship. Now, working with home, as I was thinking about this, was the most fun. It's the most painful thing, and it's the most fun. At first, we were all like, yes, we will never be late for work again. And yet there are still people who are late for meetings. Like, was there like a backup in the bathroom, or you're not able to get from the kitchen over here? And I can tell you that my boss laughs at me because I shamelessly eat on video. At this point, there is no shame in my game. If I need a snack, I've been sitting here for hours, I'm eating at people. And so, and Chex Mix, I'll crunch, I don't have any issue. And so 7 months into it, we're all exhausted from sitting here. I mean, we shortened the CSA conference to 3 sessions plus our intro because we know we're tired. We can't really sit for this long. Yep, we could sit for a long time in a building, but we know we get to get up and walk around. And so we've had to make adjustments. The other thing, though, that has been nice about this is we've saved a ton of money. You know, even though it's been a challenge, I've saved a ton of money. I don't know about you, Stefan, but I've saved a ton of money on makeup. And this is my pandemic hair. Yeah, it's not brushed. This is the way I'm rolling. And I just feel like it helps me get into my older stage. And then honestly, we all know the definition of what are you wearing underneath what you can see. My fancy pants are consistent of, do they have buttons or do they have elastic? And I'm going to tell you, friends, I'm not standing up, but I got on fancy pants. I got buttons on for you today. And so I will tell you that that's been an interesting piece of what do I wear, because I started off really strong in March and April looking good. And now we're so accepting of each other because it is what it is, and that's okay. Workspace is probably a really difficult thing, honestly, in all seriousness, because we're having a hard time. If you didn't have a home office before, being able to separate your home from work. I feel like I actually never stop working. If I feel I can come into my office really easily and just sit down and send out a couple of emails, and I'm like, oh my gosh, I don't stop. And so, you know, for those of you who are doubling as educators, your office, you also may have really terrible coworkers that are in with you. I have a bulldog that comes with me every day. He's outside this door right now because I didn't want you guys to hear him snore. He's a terrible snorer. So I always worry people are going to hear what's going on in the background, but children coming in, it's the disruptions that everybody didn't expect with telehealth. And so the disruptions, and I would encourage you to put them in the chat box, because the disruptions are my favorite, okay? So if you think about who are disruptions, at first, everybody's all really kind of embarrassed about children coming in, and they're like, oh, no, 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 it's like we don't have children, but we have them. We know that everybody knows they have children who have them, but then they're like, oh, sorry. Now we're like, come on in, let me do that. Let me do your hair for a sec. Okay, hold on, yeah, we're doing that, we're fine. And so people just keep on moving, just like it's totally normal. Dogs jump up. How many times has a cat walked across the front of your screen? Like, well, just having a good old time. And so parents are also not only the challenge for clients, but as professionals, we're trying to provide a service in a professional setting. And then you've got some people like, totally, you've got all these disruptions coming in and you're just trying to hold it together. You really are. You're just trying not to, you have to laugh because otherwise you'll cry. So all I'm going to tell you is keep laughing at the distractions, because we all need that laughter. We need that connection. We need that relationship. And so, and one of my favorite distractions, and I have to do this because everybody who knows me knows how I feel about my children, which is my animals, is I love decor in the background. Like, so right now I can see Stefan's screen and I'm like, Stefan, you're really going to have to bring up your A game. I can see that clock a little. Is that an award back there? And so, but right behind me is a giant picture of my Jack Russell. Yeah, I know. Go ahead and be judgy, but I love my dog clearly, and that is my happiness. And it's always an interesting conversation starter. So for those of you who feel like, I've got kind of a boring background, that's why you have the backgrounds. I'm going to tell you, Teams has got you covered on that. And so the thing, though, that I think we all miss with the work from home, because it felt really good at first, is that we really, again, people believe in relationships anyway. But we need to see each other. and more than flat Stefan or flat Natalie. We need to see each other. And so we miss the face-to-face interactions. And so because we're such social beings, you know, I'd like to think down the road when we come back and we're working, whatever that's going to look like, because I think it'll be some combination of hybrid between virtual and working from home, because we've made it work. So it's not so terrible technically if we can find a healthy balance between the two. Just remind us when we're complaining about going to work that one time when we didn't get to go to work. So some of the things Stefan mentioned on earlier with our clients is difficulties the same with as with communication and case management. I did not go to school to be IT. I mean, I'm going to tell you, when I didn't study it in college, I took that one class that one time, and it was the only C I got in college, but it's fine. Thanks. I've worked through it. But I mean, I learned to type on a typewriter, people, and correction tape. So for all the you young pups that don't know what correction tape is, you can Google that. It's totally fine. But some of the challenges is really like getting connected. I don't know if you guys are experiencing this, but when Alyssa was talking, there was a little bit of a delay in her connection, and it may have been in my connection. It could have been me. And so it had just a slight delay. Well, at first I would have been like, oh, is something wrong? And now I'm just like, oh yeah, it's fine. You just keep moving. But the connections can be really challenging. And before March, the only thing I thought about platforms was what kind of fantastic shoes we were purchasing from platforms. Okay, people. And so now we know that platforms are like, oh, we're using Google, we're using Zoom, Skype, Teams. And then of course you've got some people who are all a lot more with it. They're like, we use Adobe Connect and Cisco WebEx. Even the name Cisco WebEx seems a little affluent. So I know I've downloaded more platform sites to be able to get onto more meetings than you can imagine. And I think before, because we're all going to be like, before, it would have been scary, intimidating, increases my anxiety. And now I'm just like, got it. I can figure it out. And so after you figured out your platforms, and of course they're HIPAA compliant, of course they are. And then you get the challenge of getting your clients connected. Oh, I'm sorry. Not only can I barely get myself connected, I can't get you connected. So I can tell you at Intercept, one of the things that we did, and I know that NCG has helped their clients as well, is we have people who help people get on before their session starts, because that's the right thing to do. And so if you want to increase your show rate, you're going to help people get on. And so just one of those things that fall under and other duties as assigned. And so, you know, honestly, being online with folks really can be like herding cats. And so once you actually provide the service, you know, you're providing the service with all these distractions. And the nice part about this is that, again, we're just giving each other some slack. We're giving each other some forgiveness, some grace. Everybody's kind of gotten a lot more patient with that. And so I'm going to tell you, I'm going to talk about staff anxieties, but please put in, I see people are like throwing in chats, which I totally love. Please throw in your favorite interruptions and distractions that you've experienced over the last 7 months, because honestly, it will really make people feel great. And then the last piece is the staff anxieties before I hand it over to Alyssa, is when you add all of those things that I just talked about, and oh, by the way, you're experiencing your own personal COVID-19, and how's it going to work for you and your family? The question that's constantly going on, I think, always in the back of our minds is, am I making a difference? Like, what am I doing? And am I connecting, like not IT connecting? Am I reaching my client and am I helping them? And in the end, yes, you are, because you're there, you're present. And even with the distractions and their distractions, because honestly, I think our clients have better distractions than we do at times, but we give them a good run for their money. I think that's really, we are making a difference. And so Stefan did mention, you know, how has our anxieties really played out? Toilet paper, people. I don't even feel like we need to go any farther than that. toilet paper, but I'm not gonna lie, there's a couple of rolls downstairs extra just in case people get scared in the winter. Then everybody, you know, it started with toilet paper, and then we all made bread, and which there was no flour. Everybody knows I don't cook. Let's just go ahead and do that. So nobody can cook the bread because everybody's showing videos. And then we all know the elastic got too tight. That was the moment when we had to find new alternatives. And so this is where the silver lining comes in to help address those anxieties, is with, you know, we started working out again. We figured out how to work out when the gyms were closed. We went outside. Look at the sun outside today. We went outside. That's neat. And so we went outside and we started biking, which the bike industry really appreciated. We went hiking. We started meditating. We did lunchtime walks, because I mean, who gets lunch? We do. And so don't overschedule yourself, friends. And then we started doing all kinds of things, cooking. I can tell you, we bought an Instapot, again, not cooking. And so, but I am the beneficiary of that. And so there's just so many things that people have started picking up. Please throw in the chat box any hobbies that you guys have picked up, because you never know who you're going to inspire as well. But I think the most important thing we found was the people we live with. We found our family at home. And so there's more time spent with our spouse when we were forced to slow down. And I like that. It's interesting when you slow down and you actually talk a little bit more, because it's relationship. So Dr. Ward, would you like to take over with a little more unrest?
Sure. So, you know, at this point, we're kind of shifting out to the larger impacts that were felt more broadly by everyone. And I want to start off by this section just by acknowledging that, you know, this is a white panel. This is a panel of three privileged white voices. And we are in a period where we are dealing not just with a pandemic of COVID-19, but a simultaneous reckoning around the pandemic of structural and institutional racism in our country that affects our members, all of those that we serve, but also our workforce and our colleagues. And so at the state level, there's a level of responsibility that comes in working in state government as there is an awakening and reckoning around these issues, to not just be attentive to COVID-19, but to be attentive and responsive to that pandemic of racism and how it is intersectional with the health pandemic of COVID-19, how COVID-19 unveiled and really exacerbated health disparities that are part of racial inequities. How do we attend to these at once? And how do we give them the attention they deserve at a system level? And, you know, at the state agencies, that's resulted in a lot of simultaneous work. So while we've been working on pandemic response, many of us have also been working on racial equity response within the work. And some of that is about access to care during this time, but some of it is about how we make meaningful changes right now to drive equity, both in how we move initiatives forward, how we tackle the pandemic, but also how we operate as state government. And so I know, you know, on the Medicaid side, we have moved towards a thorough effort at looking at all of our policies through an equity lens. We've hired a chief diversity, equity, and inclusion officer at Medicaid. We've participated, my team and myself have participated on the Department of Health's state health equity work groups, as well as within our own DMAS health equity work group. So there have been just many different levels of trying to attend to the needs of the system, and then the impact that the social unrest that has happened around us during this period has had on folks' stress levels, on on managing and communicating with people right now. We have been in the early COVID for many months. We were doing for the first time ever public open stakeholder calls from our behavioral health team at Medicaid. You know, at times we had 450, 500 people on these calls. And that was not something we had done before, but we were updating people on the flexibilities and policies that we were lifting, and just trying to gather information as well live from folks through the Q&A about what was going on. Because at that beginning time, we really didn't have our handle on what was the downstream effects of the decisions we were making, and we wanted to try to get that flow of communication happening. And on one of those calls, we put up a Black Mental Health Matters graphic and spent the first portion of the call talking about and acknowledging the disparities in racial inequities in mental health access, and in the impacts of mental health challenges on communities of color. So these are things that before COVID-19, I can't imagine happening in this way. So it's really presented an opportunity to have much and long needed, very public conversations about these issues and really push the conversation forward. But it's also been very stressful. So, I'll acknowledge too, as a white woman leading a team of mostly Black identifying people, it's also been a really big period of growth in understanding the power of language and of listening, and of that towards our providers and stakeholders as well, and how we work together to solve these problems, how we adopt a level of humility around our own ability to do so, and our own awareness of all the issues, and courageousness in walking into those hard conversations, and knowing it won't be perfect and we'll mess up. And that's a lot to take on in the midst of working in healthcare in the midst of a health pandemic. So I want to acknowledge just all of those social factors that it has been about, from the individual and service provider level that Stefan and Natalie have acknowledged, all the way up to, kind of watching the entire world change on all of our devices. And then some of us, being out there and being part of the protests, and just the impacts that has had on us as a society are certainly going to have long-standing waves, or as I think on the screen we had the domino effect. It's going to make, I hope, long-lasting impact on the way that we have these hard conversations and drive policy change that's needed to be there for a long time. I want to talk a bit about the 10,000-foot view of the impact of COVID-19. These are some slides that we've shown publicly over the last few months as we've been crunching our numbers. And these are slides from the last run that this goes through is May. So there's some caveat around these numbers, but these are to explain a phenomenon that we were seeing early on at the high system level during COVID, where primary care and physical specialist visits were falling off a cliff early in the pandemic, when people were in lockdown. They were not going to appointments. They were not going to their well visits. And really, they weren't even going to ERs. People were really staying home. And that was having significant economic impacts on those providers. What we saw, interestingly, on the behavioral health side, which we're still digging into interpretation and understanding of this, because I don't think it's a black and white issue, is that we were seeing a relative stability in the delivery of services and the utilization of services. Now, some of that has to do likely with the fact that we moved to unprecedented allowances for telehealth delivery of behavioral health services, which we did overnight and was really there are no words to describe what it took to make those decisions and operationalize that. And we did that. We made that decision at Medicaid because we recognized that the most important thing was that our members have access to services. And there's no way we could have known at that time that we made that decision how long we would be in this or what that impact would look like. But we did the best that we could with the information at the time to open everything up. So on one level, this showed us that there was some good impact of that in that people were able to continue the services. I know it was wonky for many service providers. It wasn't going to be a perfect match because particularly in our community, behavioral health services, they hadn't been allowed to do telehealth before. So it was a huge, tremendous effort and shift to move people in that direction so quickly. And they did it, the providers did it. And it was incredible to watch. What it meant was we saw utilization remain stable. And so that did have some impacts dynamically in the system where we have to wonder what that means for the future. So does this mean that, okay, everybody just got what they needed? I don't think that's necessarily the case. I think what this shows is the need didn't change. And if this change has remained at this level of intensity, what might it become? What is to come in the future? And this is also a sign of the resiliency and commitment of our providers to get out there and to provide the service. But it doesn't mean that there isn't more need that isn't being met. It's just what I'm trying to say. We can shift to the next slide. There were some interesting levels when you kind of disaggregate the data, which we don't have available here. We can show at the community mental health and rehab services level and also at our arts program, our substance use disorder services level, that we saw this relative stability in the services. We know that there were anomalies to that, particularly in group-based services, which were restricted early in COVID in terms of their ability to be delivered in a group. So therapeutic day treatment, psychiatric rehab, some of these services really struggled and continued. Some of them continue to struggle, TDT in particular, because of the closing of the schools and just the intersectionality of systems and the impact on people's ability to provide and participate in the service. This next slide shows that we actually did detect early on an increase in need for art services, and we saw increased utilization. That overlaps with what we were seeing from VDH in the first quarterly report around overdoses for all substances. We were seeing increases that were showing higher rates than ever before, that were taking us back to before the arts implementation in Virginia. And that is not just COVID, that is another intersection of factors having to do with national trends around the opioid epidemic that are beyond the scope of this conversation. But we are seeing that there's a sustained and intense need for behavioral health services and substance use services, and we don't anticipate that that's going to go away or lessen anytime soon.
Next slide, Alyssa.
Yes. And this is you can see this trend there for the substance use services going up. And we are rehashing these and getting fresher numbers now that claims have come in over a period of months. Because it takes about 3 months for us to have an accurate read on a full read on the utilization. Next slide. I do want to acknowledge before we move forward that one thing we did also want to note was the PPE problem. And what a journey that has been. There will be talks about that as a public health issue for decades to come. But, we know that there were so many questions in the beginning there, we were even receiving information from the federal level that masks weren't necessary, that masks weren't helpful. They weren't a recommendation from the CDC. And then all of a sudden, the tide turned and we all needed PPE. We didn't know what kind of PPE was necessary. And there wasn't clearly enough PPE being manufactured to meet the need of the workforce or the general public. And no one was quite sure. A personal story I can remember hearing really early on through personal connections that RBHA here in Richmond didn't have any, it was really, really low on masks. And I was going around to friends who were making cloth masks to see if we could get cloth mat, like handmade delivery of them. And RBHA wasn't sure if they could even take those donations, because at that time it was like, I think we have to have N95s or we have to have medical masks, and can we even use cloth masks? So I will also always remember that period of trying, where I live up here on this, 10,000 foot view, zooming down in that moment and being like, so struck by, like, can I get to my local CSB? Like, can I get my personal friends and community members to get masks to get over there? Because I was dancing between that really high level view and worrying about my immediate community at that PPE level. So yeah, that's been a big one, and one that I know we're still struggling with on some level.
Yeah, and just kind of jumping in, because we're going to go into the next slide, but a PPE for us, when we realized we needed masks, and we didn't realize it, we all knew we needed masks of some level. And the beauty of the masks from a national level is the fact that everybody jumped in. I mean, people were making masks like it was their sole job. And through my sister, somebody who made their mask for their business, she made Intercept 1,000 masks. And I went to North Carolina, drove down there because it was faster than mail to pick them up, and then we distributed them. So, it goes back to resiliency of people. And then when there is common need that everybody agrees and believes in, it's amazing what we can accomplish as a community and as a very broad community, as a nation. So, which is silver lining. So we're going to transition into the light part, and everybody should be noticing that beautiful photo if you haven't gotten to my wonderful back to my pandemic hair. Beautiful photo that is an actual Dr. Alyssa Ward original, Zero Filters, from Vermont. And she took that photo, she shared with us that she took that photo. And if that doesn't scream hope, there's nothing that does. So thank you, Dr. Ward, for taking that photo, because it actually is very beautiful. So I'm going to talk about engagement and how we get telehealth engagement. But there's a couple of pieces about engagement and how you got to get there. So first, I want to talk about barriers. As mental health professionals, we know that all the barriers that were there before, oh yeah, they're still there. They're still there. They didn't go anywhere. But then they're exasperated by you can't, you shouldn't, you should wear this, you shouldn't do this. And then a whole bunch of personal beliefs. And so some of the common barriers that we're all very familiar with, and again, use your chat box because everybody's using it and it's a lot of fun, is reliable transportation. Everybody knows that's probably one of the most common things that we all hear. And I feel like, because Alyssa's on here, I feel like, eek, Medicaid transport. So sorry about that, but Medicaid transport, when it works great. When it doesn't, it keeps people from using it. And so it's like a double-edged sword with Medicaid transport, because we need to get our families connected to their children or to their loved ones, because again, oh, look, common theme, relationship. So important for our people to get better. That's a huge factor in wellness. And so, so beyond transportation, childcare, always been one of like top 3. And then people really, if you think about it, especially parents, when they're trying to help get their children services, you can definitely hear parents, the angst and worry from a barrier standpoint of, if I have to miss one more time, I'm going to lose my job. And so, and also the impact that missing school's a protective factor. We want our children to go to school at, whether it's virtual, part of the time, half of the time, however you want to do it, go to school. Everybody loves the structure that school provides. We all do. Long wait lists have been common, and they're common in both rural and urban. It just impacts them a little bit different. And so there can be wait lists in rural areas because of lack of providers, because I don't know why people wouldn't love going out to sunny Wise County. It's very nice out there. It's on my way home to go back to Tennessee. That's my eyes for you. But also urban areas. So there can be long wait lists for specialty providers, and because there's more people, there's going to be a wait list. And so, and a lot of our folks have reported feeling overwhelmed, or they're just too busy. I mean, we can service some people to death. We love some services. We really believe in them. It's why we do what we do. But we also have to find the balance to allow for normalcy in our families, for them to feel like a family so they can get back to being a family. Then there's cost-related barriers. Some of the cost-related barriers, again, things that we know, traveling greater distances for specialized services. And for some of our families who have children who may have to be placed in residential care, or people who are placed inpatient, and there's no acute beds that are in your community, and you have to go to Tidewater to get them or to see them, it can take 5 to 6 hours to drive across the state. And so that can be a challenge. And so overnight travel cost. And then families, and this is no different than the elderly population who have to choose between, do I buy food or do I buy my medicine? We all know that we've heard that before. Do I pay a bill, or do I help get the copay, or do I get services? And so the other biggie barrier that's like way up here, that's so elephant in the room, but it's not like we're all talking about it in our everyday conversation, is stigma. Stigma and lack of understanding about mental illness are two of the biggies that I think telehealth can really have a great impact on trying to normalize mental health services, because so many people are used to now having access to their PCP. So now the fact that we've opened up the door, really, I mean, Alyssa and her group just opened the door wide open, was like, come on, people, everybody get on the bus. Let's just go, everybody go. By allowing telehealth in pretty much all the services. And that's amazing, because that wasn't something that we would have been like, let's do a slow roll and see how that works out. They were very courageous in making that decision to say, we're going to do it, and we're going to let the chips fall where they may, and then we'll figure it out as we go. But we can't not serve our clients. And so, you know, stigma is the one thing that doesn't discriminate against age, culture, socioeconomic. Anybody can have a mental illness. And sadly, mental illness, as we all know, is still not seen the same way as a physical illness like cancer. Nobody's walking around at the cancer ward saying, well, you could have done something differently. You're just being lazy right now. Why are you being so lazy? You need to pull yourself up. And so, stigma and then a general lack of understanding about mental illness, and that it's treatable. That's the crazy part. People don't realize that there are things we can do to help them overcome that. And I'm like, it's treatable. It's okay. And so telehealth really adds that extra oomph, and it helps by increasing engagement through ease and convenience and making services readily accessible, which is fantastic. We actually are bringing, it's no different than this training itself. We're bringing expertise, hopefully you believe that, to you guys, because we're coming to you. You don't have to come back to us necessarily. So we're bringing our services to families, and those barriers start to kind of slip away as we move forward. And the other thing that's really important is, whether you're from a rural area or whatever, telehealth offers anonymity. I saw this one in doing some of the research, and I thought, gosh, that is so true. Because I'm from a real small town in Tennessee, and we only have like 2 stoplights, and yes, all my eyes are long, but everybody knows everybody. And whether you go to the same churches or you go to the grocery store, everybody knows everybody. And if you're seen talking to the clinician, and God help you if the psychiatrist, if you're lucky enough to have one in a rural area, you know, everybody looking at you like, you know them well, you know them real well. And so this offers anonymity, and it really allows that privacy, really allows someone to say, okay, I'm going to try it. Nobody knows I'm going. And then build that confidence to say, when they start seeing success, to say, I did that. I feel good about this. And it does allow for a new way for hope to come in. And reduce wait lists. Again, we all know, Lord, we've all tried to make appointments with psychologists, psychiatrists, specialty clinicians. To get a psychological can take months on a wait list, people. So the nice part is that telehealth is kind of erasing lines, and it says, oh, well, I feel totally comfortable being able to see this provider over here who has a specialty, and I can get in faster because the network's expanded. And with that expansion, which is fantastic, it allows us to customize care. The customized care is so important because it's something that, definitely commercial insurance is doing, but really looking for health homes, home health, basically the concept of really being able to receive your primary care and your behavioral health care all in the same location. That's my easy way of saying it. And so it integrates behavioral health and primary care together, and it allows for collaboration. And what does that ultimately come down to? Better continuity of care, better outcomes, reduce cost. And when you reduce costs, it allows expansion of more services to others. Because it's not like, oh, we're just going to keep all the money. No, we want to serve as many people as possible. And that really is CSA at its core, the most services while being cost effective. And so being cost effective allows us to serve more. And that's a huge passion. So Medicaid members typically have their no-show rates are between 30 and 40%, and sometimes even higher, as high as 50%. And so I know Dr. Ward would be able to say, yeah, we'd love to have more providers, but with a 50% no-show rate, they're nervous. What does telehealth do? Telehealth starts to decrease those no-show rates pretty significantly and allow for providers to feel more confident that they're going to be able to make a living, because there's nothing wrong with making a living, people. We have to get paid, but we can help people, passion, and meet our needs. And so what this does is it really does allow us to expand the network of providers by really, it's that. It allows us to expand the network of providers. And so lastly, just one thing I wanted to hit on, and I brought up to Stefan and Alyssa the other day, is with increased access comes equity. And with that equity, expanded networks offers clients more choice. Individuals and families can seek out clinicians and practitioners who align with their culture, with their race, their personal beliefs, and even disabilities. I had shared that my mom has Parkinson's, and as part of Parkinson's, medications to treat Parkinson's can also create Parkinson's psychosis. And she experienced that from one of her meds. And I can't begin to tell you what a nightmare that was to try to get treatment for Parkinson's psychosis, to try to find a clinician who can provide therapy for her. Oh, and by the way, there's no specialist in Tennessee. The one that we needed her to see is in North Carolina with her Parkinson's specialist doctor, the movement disorder doctor. And so we're driving her 6 hours between appointments each way. And so I can tell you that opening up choice and availability, and for people to feel comfortable to meet a whole slew of needs is so important, and telehealth is a way to do that. Stefan?
Yeah, thanks, Natalie. Folks, because we have 10 minutes left until we're supposed to be going into a question and answer, although I think the CSA team will allow us to kind of go a little bit into that. But because of that, I want to start getting through some things. Natalie very poignantly talked about the importance of telehealth and the positives associated with it. Of course, there are numerous technologies and skill acquisitions that are important and that we've kind of gained during this time. Necessity is the mother of invention, and we have certainly had a lot of necessity in the last 7 months. I can tell you that I think I'm more technologically advanced than the average person And I really have no idea what the heck I'm doing. Although this has been a tremendous learning curve, because when you're forced to work in things consistently, you get thrown into the pit. You learn very quickly how to utilize the tools to get out. Natalie mentioned, she said, we have so many different platforms. Is it a Zoom world? Is it a Google Meet world? Are we talking about Skype or WebEx? But these technologies have become very commonplace, if not standard operating procedure. And I'd like to show you something, to a little bit of levity to the mix. I want to show you a video.
Hey, Paul. Thanks for being here on time. Paul? Hey, Paul, can you hear me? I can hear you. Can you hear me?
Yes.
Hey, Tyler.
Sorry I'm late. I'm having a hard time connecting.
1 second. Paul's having a sound issue.
I can't hear you. Try adjusting your output setting.
Can you hear me?
It's the gear icon.
Tyler, are you on hotel Wi-Fi?
Yeah, well. Never mind, I got it. I just had to change a few settings.
Great, great.
Maybe
Get started then.
Oh, great. I think your mic is like your speakers.
My mic? Do you have headphones?
Going to put them on.
No, I want you to smell them. No, I want you to put them on. Hey, Beth.
Hey everyone, sorry I'm late. I had to download a new version of the platform.
You should plan extra time for the updates. There's pretty much one every time.
Sounds like someone just joined.
Hey guys, it's John. I had to call in. I'm stuck in traffic. Have I missed anything yet?
No, it would have been nice for you to join the rest of us, but we'll see you when you get home. All right, while everyone is here, finally, Tyler, do you have that financial report?
Well, it's been the last few weeks updating our books, and I got some great news for you. Schedule from this point last year. We had a great Q1.
We lost Tyler, I think.
Am I frozen? Hey, Trip, I think we lost Tyler.
Yeah, I know, we lost Tyler.
Hey guys, it sounded like Tyler was cutting out.
We know, John. All right, while we wait on Tyler, why don't we go over all of the reports? Beth, are you with us?
Oh yeah.
Okay, everyone, I know some of you have to leave soon, but I just wanted to go over a couple of the curious reports. Okay, excuse me. My wife's out of town this week. Daddy's, so sorry. Okay, you just spilled grape juice on the carpet. Daddy is in a meeting. Tyler, can you go over the numbers one more time, please?
I thought Beth had an adjustment. Hey, Beth?
Yeah.
Sorry, guys, that's my iTunes.
Hey guys, hang on. I'm gonna join in. Hey, what platform are you guys on? Skype? FaceTime?
It's in the invite.
Oh, never mind. I see it. It's right there in the invite.
Okay, now I can see everybody. Let's reschedule and let's just do a regular old conference call, okay? Paul, can you have David send out the 9-digit passcode?
I heard you. He's been here the whole time.
All right, everybody. I'll see you later.
So I hope you enjoyed
I
that.
needed that laugh.
What I hope you guys enjoyed that as much as I did. I can tell you when I saw that commercial about a year ago, I laughed out loud because that represented every single video call I have ever been on at my company or elsewhere. Have we gotten better? Yeah, maybe not much. We can still relate to this pretty well, but we are making improvements. It's hard for people over 30, right? Anyone over 30, this is a brave new world, but we are forced into it and we're making tremendous improvements, which is wonderful. Many of these platforms become more user-friendly and agnostic, so it doesn't matter which ones we use, they're all available regardless of our desktop or mobile device of choice. We've also become more proficient in using them. We become better at using email and calendar collaboration. Does anyone get more emails now than they used to? I certainly do. I've always gotten a lot of emails. Any of you that know me for years, I said, if you really need to contact me, give me a call, because I get about 100 emails a minute. I can tell you that that's increased substantially. And it's not just work, it's personal. School, right? I used to get maybe an email a week from the school letting me know what's going on, what's happening at school this week. Now I get maybe 5 to 10 a day. It's almost as if I'm in Hanover County. It's like Hanover County just discovered the internet, and now they're having, it's like a kid in the candy store. It's communication, which is wonderful. I say this in jest, but it's so much that we're trying to manage, but we're becoming better at it. It's becoming more commonplace. Online schooling is another issue. And those of you who've talked to me about online schooling for the last few months, I've had a lot of negative things to say about online schooling. Don't get me wrong. I don't judge anybody for it. It is the reality. It is what it is. We're all doing our best. But I've never believed that online schooling is going to be a sufficient mechanism for teaching the average student. The reality is, when you think about it, and if you're honest, online schooling can actually be a wonderful medium for a lot of students. Forget the pandemic, but kids who have anxiety issues, kids who fear bullying, kids who otherwise don't acclimate well to a traditional school environment may benefit greatly from an online platform. We'll always have issues in that respect from a socialization standpoint, but that's how and why we continue to innovate, by seeing the strengths, the weaknesses, the opportunities, and the threats of any policy or innovation. And as we continue to perfect the platform, by the way, we can enjoy the efficiencies that it brings. Perhaps in time, or over the course of time, the way we educate people changes, where those who have a need or may otherwise benefit for remote learning, they can do so in a much more effective manner by being put on homebound instruction. Natalie and myself, who've worked in group home organizations, we understand the issues with homebound instruction. So foster children who are put on homebound instruction temporarily or indefinitely because of enrollment issues, how much does their education suffer? Where is the equity? But online becomes a conduit by which to help. So we can think through these things for the future. We're testing the ground right now, and I think we can do some very, very interesting things in the future. Efficiencies, innovations create more time for us, right? There's greater ease in doing our work. We can be more mobile. We no longer have to rush to the office when we're in the field to make a meeting, right? We just have to snarf down the food in our mouth so that we can access a meeting without mustard on our faces. Mills Jones, I'm talking about you, buddy. Any of our Central Virginia Partnership on Youth meetings, we've all been there. When we become more familiar and the procedures, the systems become more standardized, investments will be made as well to further improve them, to make them more expansive, and to allow them to be accessed for everyone. I want everyone to applaud right now for high-speed internet in rural and poor communities. Please, this is what we need. This is a huge equity consideration, but now we're seeing it. As Alyssa said, the pandemic exposed this. It's created a big light on where we have not only equity issues, but just dysfunctions in our system. We can improve this. And skill acquisition, rather, goes beyond the arena of technology. What about practice? As we're seeing more engagement now, which is wonderful through issues like through mediums like telehealth, we are now not having to work so much on being engagement specialists, but we have to work on honing our trade more as practitioners. It sounds like that would be easy. That's how we cut our teeth, but we become forced and conditioned to operate in a certain way. Now we can start to improve, and the impetus is for us to improve on those skills. So we need to learn to provide counseling without being able to read body language as well. This is a requisite skill. All of the distractions or the lack of a tranquil and therapeutic environment as we have face-to-face counseling, we can think through these, we can innovate. And by the way, systems like Zoom can help to accommodate that. Natalie mentioned backgrounds. If any of you see the webinars that I do, I always put interesting backgrounds in the back. Well, we can do things that can achieve more tranquility from a counseling perspective. I want to talk also quickly about flexibilities before I turn it over. Alyssa mentioned this. It is important to mention again. She's very humble and said that dealing with dealing with the systems impact of the pandemic was essentially a nightmare. It was troublesome, it was important, it was very stressful. The reality is DMAS and DBHDS did not have to fix these issues. They did not have to open it. And by the way, opening access was not easy. You might say, well, just let the chips fall where they may. But there are serious liability concerns. Statutes are statutes, regulations are regulations, and you cannot throw them away without having a tremendous amount of unanticipated and undesirable outcomes. Furthermore, as I said, the liability alone is one to give pause and say, we can't do this, let's stick to the playbook. But because people are too important, DBHDS, DMAS got together and they said, we need to do this. We need to do this. Let's do this smartly, but let's do it quickly and let's open up access. And personally, and speaking for Natalie, speaking for all the providers in the state, I want to applaud you, Dr. Ward, for the work that you heralded, for the work that your team has done, because we have saved many, many, many people's lives. And when I say lives, I don't just mean physically, I mean emotionally, I mean spiritually and practically, all because of the work that you did. We are incredibly thankful for it. We allowed video counseling, we allowed phone counseling and services that never really allowed for it. We allowed it to be done in ways without originating sites, which, you know, how can you do home-based counseling? What's the point of home-based counseling if someone's forced to go to a doctor's office to receive it? So the ability to say, listen, let us take care of people, let's do it, and we'll deal with it after the fact. It was a tremendous risk. It should be lauded. Thank you so much. And we've learned so much. We can now bring this into the future.
Well, Stefan, I really appreciate your acknowledgement of that. And I think equal and reciprocal acknowledgement is due for the provider community that really stood up and innovated and found ways to meet our members where they were, and that was at home, and figure out ways to reach them and hold them steady and protect their wellness during this time. It really has been incredible to watch. And we're in summary, since I'm aware of the time, I mean, I think where this conversation is going is that this terrible situation has allowed for us to work together towards things that we've hoped for a long time, including expanded telehealth capacity as a system. And it's allowed for us to push for prioritization of for funding of things like broadband access that are, outside of Medicaid's purview, but really highlight how this is a whole system effort. This is about funding for schools, for our public schools and the work that they do. This is about funding for broadband access. This is about funding across the system. And we, our next steps really are that now that we've kind of held this light throughout the period is figuring out how we move that forward. And we know that telehealth has been used widely. We know that the top 8 diagnoses in Medicaid billed for telehealth were all behavioral health diagnoses during the pandemic. So we know that this holds great promise for the expansion of access for our members, and for furthering equity and cultural congruence of care and all of those things that Natalie and Stefan have touched on. So where we go next is really in figuring out how, what we can do to make permanent some of these flexibilities, how we can learn from them about how our services can be delivered and what needs to change, or what the real member needs and provider needs are going to be coming out the other side of the pandemic. And so that's where we're moving now, is to listening and learning and to thinking about how things need to be made permanent or be changed going forward.
Thank you, Alyssa. So we're fast running out of time. There's a lot to be said about going forward, as well as where to shine the light next. I will say before we get into some questions, because I think we should probably move in that direction, but to kind of sum it up, we need to be involved. Natalie mentioned that being available, being with people is sufficient enough. And that is very true, particularly at this stage. We are no longer simply worrying about the behavioral health issues or substance use issues that led us to become involved in families, in any family's life. We're worried about how they're coping day to day. The issues have changed. They haven't gone away. The old issues haven't gone away, but a whole slew of new issues and priorities have come to be in its place. We must be available to people. To wax a little corny, be a light in the dark, be a beacon for hope, communicate well, consistently, strongly, meaningfully, wish each other well, lend a hand or an encouraging word. Remind yourselves and each other that this will end. We will all get through this and we will be better. Allow us to mourn. We talked about the fact that we've been robbed of mourning rituals. It's not just because of a physical death, but the death of our society, the death of our way of life. This is very, very, very powerful. How do we mourn it, honor it, understand it, talk about it? How many of us as practitioners, when we're working with our families, have even asked, how are you coping with the pandemic? Do you have questions about the pandemic? What are you aware of? What are you missing? How is this impacting you? Let's lead people into acknowledgement and into mourning. Let's engage in rituals that allow us to not only move on, but to embrace the past as well. Natalie mentioned exercise, all of our daily rituals that we do, even getting up in the morning and getting dressed, as opposed to sitting in our underwear, which is a lot of fun. What does that tell us? When we can engage in rituals that allow us to honor the past while we move into the future, this is where our mental health will remain for all of us and for our families.
So why don't we open it up to questions, Stefan? Because we've got 7 minutes. We want to be respectful of time and everybody's hunger pains.
Yeah.
So,
Okay. So this is Scott. Can you hear me?
yeah.
Yeah, so I've got a couple of questions. Let's see. One is, Stefan, they'd love the link to that humorous video. If you want to send it on to us, we'll get it out to people if that's possible.
Absolutely.
Yeah, so maybe a brief question, maybe. What are the pros and cons of using telehealth for medication management?
So I think any of us could talk about that. Natalie, Alyssa, what are your thoughts?
Well, I can say that we've been doing it. That's been something that's common practice for a good long time. And so that's the beauty of telehealth being available to other services allows that to start to pair up better. And it starts to reduce, again, it goes back to wait list. Yes, there's always going to be some level of lack of connection by not seeing that person face to face. Some of the things that we've talked about is the ability that DMAS may say, hey, we'd love for you to have some kind of hybrid piece that allows for the client to come in maybe once a month or once every certain window of time. And then the other ones can be done through telehealth because it allows convenience, but it allows the practitioners to touch them, see them, kind of idea, not literally touch them, but kind of feel like that. So Dr. Ward?
I would just say from a systems perspective that the greatest benefit to telehealth in medication management is that it supports our dearth of particularly child psychiatrists, which y'all know all too well. I'm sure anyone listening to this. We have far too few of them here in Virginia. I know it myself as a referring clinician. Very, very difficult to find a provider, particularly if the kid has any kind of special consideration or issue. And so I think that it just opens up the network. It allows for access in ways that we wouldn't have otherwise. I'm
not a physician, but I've stayed at a Holiday Inn numerous times. I can tell you that I think the biggest concern with telemedicine from a psychiatric standpoint is just being able to gauge the impact on the physiology, the vitals. You know, you can't test vitals while you're remote, but that doesn't mean that there aren't solutions to that. There are ways to address that by coordinating with a PCP or other physician. One can get these results even if you're not taking them yourselves. And that's another reason why originating sites had come about in the first place. They wanted those kinds of capabilities to be available, but there are creative ways to do it. I think the benefit far outweighs the problems.
Mhm.
Yeah, great. So here's a question many of you have spoken about, issues of equity and the impact, the disparate impact and systemic racism in our system. So the question I know it doesn't call for a short answer, but I'll put it out there anyway. How can we validate the experiences of individuals and their raw emotions who've been affected by systemic racism? And relatedly, can the data about disparity in mental health access for communities of color be shared as a resource for use in local equity discussions?
Sure. So the data that I referenced, Scott, I'd be happy to pull some of those references. I don't know that we have specific data from Virginia's Medicaid system that I can reference that easily, but there's been substantial decades worth of research, and SAMHSA has a couple really nice reports that summarize equity and access issues around race. And I've pulled a couple of those recently. So Scott, I could share those with you to share with folks.
Send those to us. Our colleagues at Virginia Tech will be sending out like a follow-up that may include those various resources. Thank you. We've maybe got time for one more. Are you aware of any observable increases in requests for mental health services for youth during COVID? Is it too early to tell? And if not, what are the early returns showing, to use an election metaphor?
So it's interesting. I was having this discussion yesterday in the breakout room that some people joined with me. And there seems to be a little bit of a discrepancy or a disparity between the data and what different providers are seeing in the field. As an example, Alyssa is showing that behavioral health has remained fairly static in terms of the need being met. Many providers, on the other hand, and NCG is one of them, has seen a huge reduction in services being initiated. Now, we're getting a lot of calls, less calls than used to, but a lot of calls. But the conversion of those calls, the referrals to services, there's a big chasm between that we don't fully understand. It could be a number of reasons, and we're still trying to get that data together. The reality is some of this is anecdotal, some of it is statistical. The needs have been growing. You can see what the CDC said in terms of their poll. We know even from historical traumas like Katrina that substance use in Louisiana increased tremendously over the course of 3 to 5 years after that event. So the increase in needs is quite predictable, in my opinion. You don't need data to show that. And I think it will continue. I think you're going to see a lot of these issues start to show themselves over the course of another year, 2, 3, especially as we start to normalize and you can let down the barriers. Once we relax and we say, whew, that's when everything will start to hit. So I think you're going to see pockets of need coming up and down throughout the next few years. But what we're seeing from a provider angle, at least speaking from an NCG standpoint and with other providers that I've spoken with, we've also seen a reduction in requests for need and or our ability to serve in some ways. So it's an interesting place that we're all in.
Yeah. So I'm going to let that be the last word from the panel. And I want to express my thanks, but for just an outstanding session. And I didn't know if this would be apropos, but I had pulled it out, kind of anticipating what you all might be talking about. And so I want to tell you a little story to close, and then we'll move into some administrative closure pieces. But this is really the the story for our whole conference, for our whole response to the pandemic that we heard about from your presenters this morning as well as yesterday. So the story concerns, and some of you may have heard it, but it's okay. The story concerns twin boys of 5 or 6 years old. Their parents were worried that the boys had developed extreme personalities. One was a total pessimist, the other a total optimist. So the parents took them to the psychiatrist, of course. And first, the psychiatrist attempted to treat the pessimist. And he was trying to brighten his outlook. So he took him to a room piled from floor to ceiling with brand new toys. And instead of jumping and yelling with delight, the little boy burst into tears. And the psychiatrist, baffled, asked, "What's the matter? Don't you want to play with any of the toys?" "Yes," the little boy bawled, "but if I did, I'd only break them." Next, the psychiatrist tried to treat the optimist child. And trying to dampen his outlook, the psychiatrist took him to a room piled floor to ceiling with horse manure. And instead of wrinkling his nose in disgust, the optimist just emitted this delightful yell that the psychiatrist had been hoping to hear from his brother, the pessimist. Then the child climbed on the top of the pile and got on his knees and began gleefully digging out scoop after scoop with his bare hands. "What do you think you're doing?" the psychiatrist asked. He was as baffled by the optimist as he had been by the pessimist. "Well," the optimist said, "with all this manure," he said, beaming, "there must be a pony in here somewhere." And I think what you've heard this morning and over the last 2 days this is another wonderful metaphor. While the pandemic may at many times feel like a pile of horse manure. See, I censored myself. That was good, right? It may feel like a pile of horse manure, but there are, in fact, light in the dark, as your speakers this morning have highlighted. I leave the conversation, uplifted and optimistic myself about how the challenges that the pandemic has laid in front of us are great, but not greater than the ingenuity and the compassion and the resources of those of us who are helping our consumers and everyone else fight it. So thank you guys very much for leaving it on that uplifting note.
Scott, Natalie and I would also like to remind everyone out there, there's a couple more days of early voting here in Virginia. We would like to remind you with our accessories to participate in our democracy.
In fact, I'm going to talk about that in a second. So thank you. Those are very nice voting encouraging hearings.
They're nonpartisan. They're just go out and do it.
Yeah. So
just do it.
So I'm going to get to that in a second because the word of the day, the secret word to win one of 2 free registrations to next year is the word vote. So in a minute, I'm going to call out a couple of names. And if you will send email to edensley@vt.edu after I call your name, if you do that by 2 o'clock, you will receive a free registration to next year's CSA conference. Assuming it's in person and we'll be able to charge anybody. But I'll read those names now. So the selected winners are Amanda White and Beth Renswick. So Amanda and Beth, if you're still out there, if you send an email to edensley, D-E-N-S-L-E-Y, at vt.edu with the word vote in the email, we'll make sure you get hooked up with a registration to next year's conference. And so if you have already voted, please raise your hand. No, I can't raise my hand. If you haven't voted, do you have a plan to vote? And as they say in Chicago, vote early, vote often. let me close us today. First of all, you know, this business about platforms and Zoom meetings, let me tell you something. I hope you experienced over the last 2 days a seamless experience with this technology as we presented this conference to you. And I can tell you, if it looked seamless to you on the back end, there was a whole lot of effort going on. Well, you saw it on the front end. On the back end, there was a whole lot of effort and expertise brought to bear to make that possible. So I want to give a thanks and a shout out to the team at Virginia Tech, Zach and Leland and Elaine and Susan and Caroline, who helped in oh so many ways make this conference possible for you. My partner here at Office Children's Services, who took a lead role, is Andrew Relaford, and who you got to see on camera. So thanks to all of you. And, you know, the fact that we haven't gotten 1,000 emails about why people couldn't hear or see or any of those things in that really funny video that Stefan shared with you is really a testament to their work. So we hope, all of us here at OCS hope that the time you've spent with us has been worthwhile. We are always appreciative of all of the efforts, large and small, known and unknown, that you bring forward every day to bring our system of care to life, and in that, do right by our citizens and our children and our families who are most at need. And with that, I'll bid you adieu. Look for some emails from Elaine at Virginia Tech. There'll be a survey, you know, who knows what else. Keep in mind, as Andrew said, if you missed any part of it or just want to watch it again, we'll be letting you know where the recordings will be available soon, along with the PowerPoint decks. And again, Amanda White and Beth Renswick, you have 2 hours to send Elaine an email with the word vote. If not, we'll go down the list and Elaine will get in touch with who's next on the list, which I think is me. So thanks again. Have a great weekend. Don't forget, turn the clocks back. You have until Tuesday to, if you haven't already, to participate in our democracy and have your voice heard. Thank you all and have a great day.